Good morning, ladies and gentlemen. Thank you so much for joining us today. This workshop and systems review, screening for diagnosis and referral. Dr. Jibril, are you with us?
Yes, sir.
Please,
Sorry, I've just joined. Yeah.
Okay, wonderful. Please, I think you and Hafiz, there's something that I want us to do, because it seems we'll need to do practicals for this course, apart from the case studies that we are going to look at on Wednesday. So what we are going to do
hands-on.
Yes, hands-on, exactly. So as I go through, there are some tests that we'll need to take note of. So as I discuss them, I'll let you know which ones to take down, so that these are the ones that we are going to have the hands-on with. Yes, as assessments that will help us to be able to know when there is a red flag or a yellow flag. So please just take note. As I discuss, I will mention the ones that are going to be part of the practical. Before we start, you are all welcome. Let me ask anyone that has any experiences with the issues of screening for problems in organs of the body and refer to physicians. So have you ever had a patient that came with a musculoskeletal problem, for example, and during your assessment, you realize that it wasn't a physiotherapy case, and you assess the patient and you saw the indication for referral? Any experiences? Just few minutes before we start, let's just see what your experiences are about this. You can raise your virtual hand. Yes, Adiolu Babatunde. You can unmute and speak, please.
Good afternoon, sir. Good afternoon, everyone. Good morning. Sorry.
Morning. That's okay.
Yeah, a patient was referred to us, I think sometime 2 years ago. And
Yes.
He had complaints of, shoulder pain radiating to the clavicular area.
Okay.
Actually, it was a baby. So the baby, they referred to us and we examined, and we observed that there was actually a fracture there.
Okay.
So because it was obvious on palpation, the place was moving somehow. There were micro movements there. So we just referred straight to the orthopedic unit. There was only continue with that, and that's what we had. And after they had done the needful, they referred the patient back to us about a month later to continue the treatment.
Okay.
That's it.
Now, a question. The patient, did the patient come to you directly, or was the patient referred by another physician, or by the same physician you referred to?
By a nurse from the, they complained to the nurse, this nursing home.
Yeah.
So they now say, maybe we should go to general hospital.
Okay.
So the first doctor they met at the pediatric unit just said, goes for physio.
Okay. Okay.
Now just looked at it and said, just go for physio. So on examination, we observed the fracture and then referred to the orthopedic unit.
Okay, so that was a first contact case. They were not seen by a physician, they were sent to you directly. And the fact that you were able to screen them and realize that there is an organic pathology helped you to know that there is the need for another professional to see the patient, and you referred. Because if it was a physician that referred the case to you, then I would have thought of it as a missed diagnosis, meaning they did not diagnose that, and you had to find out and refer back to them. But the fact that it came to you directly is a first contact case, and you were able to identify the need.
No, the baby was referred by from the doctor in the pediatric unit. So most likely, so that's most likely a misdiagnosis. Just looked at it.
Yeah, exactly. Yes, because I heard you say it was referred by a nurse. So I know usually in our system, nurses don't refer directly to physio.
The nurse said they should go to the general hospital. So when they got to the pediatrics section of the hospital, the doctor just looked at it and said, I was not lifting the hand. This is a physio case. Just goes for physio and refers straight to physio. So we now observed that there was actually a fracture there. And we had to refer to the orthopedic unit.
Wonderful. So this is a clear case of a missed diagnosis. So if a physiotherapist is not able to screen to know that there is an organic pathology, something that is not within the scope of practice of physiotherapy, and refer, that patient will continue to have that organic pathology, and your treatment may only relieve the pain, but it will not take care of the source of the problem or the cause of the problem. And at the end, the patient will continue to come without discharge. So this is one of the reasons why we're having this course. It is part of the DPT program. It's a compulsory course in DPT, because DPT gives you that chance to be a first contact or direct access professional. And for you to be able to be a first contact professional, you must be able to screen all the systems of the body to know if there are underlying diseases. So thank you so much. That's a very good one. Can you please lower down your virtual hand? Mr. Anozie.
Yeah, thank you very much. I've had one case like 2 years ago when it was actually first contact. The person came in. He was, like in his early 40s. So can you hear me?
We can hear you now.
Yeah. So he's in his early 40s. He came and he was complaining of low back pain, lower back pain, and all that. So I was to do my assessment and I performed the usual taking history and asking how did it start, and there was no history of trauma. There was no history of, and this person is also is a banker. So I was like, okay, I asked around, the sitting posture, do you sit for too long and everything? Or do you drive? So I went around all the occupational history and everything to find out if there are things like that. And I eventually went in to start my examination, doing the palpation, the movement tests and everything. But it was like when I was doing all those things, it was mostly negative and negative, but he actually, was talking about the pain is still there. So I wasn't able to conclude, the diagnosis on that day because I was like, what could have been causing the pain more? So, the day I did the assessment, the pain was not, he said the pain was around 5/10. So I was like, okay, let me see what I can do about it. So everything seemed to be okay. So I was a little bit, like worried what's going to be the problem.
Sure.
And I asked him to observe the pattern of pain. I want to know what aggravates the pain, what relieves the pain, what time of the day do you feel the pain, and the other things. So in his next appointment, he came. So I asked further questions, and he was able to explain to me also that he also experiences occasionally the pain. He experiences pain, something like a heaviness around his testes, heaviness around the testes. So I asked further and everything. He said, heaviness is just heaviness. He's also feeling pain and all that. He said, and whenever that pain comes, it makes the pain at the lower back more painful. So that made me to start thinking, okay, this is painful there and this and that. I was thinking towards, could it be a referred pain and all that? And he said, when the pain is not there around the testes, it's like the pain in the lower back also reduces. So I was like thinking, oh, there could be a relationship between these testes and all that. So from that, I actually wrote a referral to him and asked if he could go and see the urologist and all that. So when I sent him there and everything, eventually they were able to discover that he had a varicocele. So which will now require a varicocelectomy, and while they did that, and he was actually the pain gone after like a few weeks after having that varicocelectomy and everything. So I was very happy that I was able to be able to detect that, this is not just in the realm of physiotherapy, that he needed to go to the doctor and all that. So then I was able to now balance again, and I had to read more, and I found out that there is actually a relationship between people who are presenting varicocele with it can't have a relationship with lower back pain. So that was my little experience. Yeah.
Wonderful. That's great. So there's another very important reason why physiotherapists should be able to screen for all systems of the body, because you can have a problem and you will assume it is at that locality where the problem is. For example, say back pain that you reported, and you will think it's a musculoskeletal problem, either with the disc, with the soft tissues in the back, and that, the muscles, and whatever it is. But at the end of the day, you do all your tests, they are negative, and you wonder, if the tests are negative, why is the pain there? And then later, you'll now realize that there are other symptoms in another organ that could refer pain to that musculoskeletal a part of the body, and then you will now refer. Now, but another question is that, Mr. Anozde, can you please lower down your hand so that we'll be able to know if there are new hands? Now, another case, yes, another scenario. Let's assume there were no symptoms, any urological symptoms, so no symptoms at all, and your musculoskeletal presentation is there, pain in the back, it looks like a musculoskeletal one, but all your tests are saying negative. What then would one do? Will you just say that it's still the musculoskeletal, or what would one do? Anyone wants to make a comment on that?
Yeah, can I just make a brief
Yes,
comment?
sure, go ahead.
Most times I usually, because I believe that collaboration with your colleagues can also give insights. So most times I usually will ask a senior colleague or someone who I feel has more expertise, please, can you just run through the presentation to the senior colleague and look at and say, okay, this is what I've done and everything. Sometimes I've also found that maybe I've missed out a particular assessment that I may need to do. That sometimes we will now like, okay, do we think that this patient would need further investigation to really be able to find out something? But most times I try to run it through someone who is more experienced in that field. Then sometimes would I say we can recommend this patient would need more maybe laboratory investigation or radiological investigation to be able to give us more insight into what is happening and all that. But where I work, usually you have to also still liaise with the GP in charge of the patient to be able to run through that. So you more like just make a suggestion, but not like you are the one prescribing those the investigations. Exactly.
Okay. Wonderful. So that's a good one. So what we are going to do today, we are going to learn how can you yourself, without seeking for someone's help, be able to screen all systems of the body, that even if there are no symptoms in those organs, or the symptoms are seen when there is a problem in those organs, if they are not present, they are not manifest, the patient cannot report them, or tests cannot pick them, how do we know that there may be a problem in that system? This is what we are going to do. And that is why it's called systems review. We are going to see the difference between systems review and review of systems later in the presentation. But what is very important is the fact that a patient comes to us. The physician has either missed the diagnosis, or at the time the patient came to us, symptoms have not appeared. And therefore, even the physician may not have picked it up, not to even think of missing it. Or maybe the patient is at risk of having a problem in that system, and we want to see those signs, the risk factors, that patient may be at risk of having that problem, so that it can be referred for such to be prevented, so that the disease does not come. Or maybe it's at early stages. The symptoms are just mild, and the patient does not even care because it's very mild. So, but you should be serious about it so that they don't get worse before treatment begins. I'm very happy with the two case studies that we have had. They are very, very relevant. But what we are going to do today is to know more about how do we know when someone needs to be referred, which is called a red flag, and when we need to continue to investigate and follow up to make sure there is no problem that needs referral, or if there is at a later time, I will refer. So this is all about systems review. It's in the textbook that these slides were developed from. It's called differential diagnosis in physical therapy, screening for referral. I added the diagnosis because the screening, we know diagnosis is about ruling in and ruling out. That's why I add the diagnosis, because if we screen to refer, just like in the second case, said I thought it was my case, but later I realized it was a urological problem, and therefore I referred, meaning I have ruled out my own diagnosis. I ruled in the possibility of a diagnosis from another professional, another type of diagnosis that's not within the scope of my practice. So that's very important to take note of. Now, I would have asked if people have experience with courses or trainings in systems review, but possibly we can do that later. So let's look at some introductory aspects. Very important to define these terms. Diagnosis. What is a medical diagnosis? What is a physical diagnosis? What's the difference between the two? And what is a differential diagnosis? So diagnosis is the identification of the nature of an illness, disease, or problem by examination of the risk factors, symptoms, and signs. This is very important. If you have joined us in the evidence-based practice class and the clinical reasoning and decision-making class, you would have heard me talk a lot about risk factors, symptoms, and signs. A few days ago, I believe on Wednesday, when we had the clinical reasoning, I took almost an hour discussing the APTA template on patient clerking. And we looked at how we collected data on biodata, looking at the age, the gender, the address of the patient, and how we used information about risk factors to be able to interpret that data collected. We also looked at past medical history, family social history, and drug history, and how we used knowledge of risk factors to help us in collecting the information, but also in interpreting the information. I remember I gave an example with cardiovascular disease. I said someone that is 70 years old or 60, that's a female, all these are biodata. Then we are looking at social history or family history. The parents of that person had a heart disease. Then social history. The patient smokes, and we say the smoking is not just any smoking, 1 stick per day. No, we are talking of, say, 10 sticks per day for many days. Checks alcohol, the lipid profile is high. All these are risk factors. All put together gives the interpretation that the patient may have a cardiovascular disease. So this is part of the process that you narrow down to be able, not cardiovascular system problem. So cardiovascular disease, whatever it is that you refer to, but this is the process of diagnosis. You use risk factors. You interpret the results of examination to be able to narrow down from thinking of everything to now narrowing down to a system of the body. You now go to symptoms. We say symptoms is at the level of history that you discover the symptoms that the patient has. Therefore, you're asking the questions. Chief complaint, of course, will come before the symptoms. I remember we said at that level of risk factors, you don't ask the patient about their chief complaint. Because the moment you ask the patient about their chief complaint, there's going to be bias. You are going to focus more on assessing things that have to do with that system of the body where the chief complaint is. I've explained this during the clinical reasoning class. By the time you ask the patient, what is the chief complaint? I have pain in my chest. Then you now continue with the symptoms, asking questions about the symptoms, the type of pain. When does the pain come? Say it is located on the left side, and it increases with activity, reduces when I'm resting, and you now go to your examination, you find out that the pulse rate is abnormal, you do a number of other tests. At the end of the day, it helps you to narrow down to one particular condition. And this is what diagnosis is all about. You identify the disease by assessing the patient using information about the risk factors, symptoms, and signs. You continue to narrow down from thinking of every condition possible until you rule in one condition and rule out all other conditions. That is diagnosis. But when you talk of condition or disease or illness, it's too general. That is what now determines what type of diagnosis you're after. Is it a medical diagnosis or is it a physical diagnosis? So the process is the same. We're dealing with assessing risk factors, symptoms, and signs in both medical diagnosis and physical diagnosis. So usually I will ask this question: what's the difference between medical diagnosis and physical diagnosis? And many people, many physiotherapists, how I wish I did that. Many physiotherapists will say that the difference is that in physical diagnosis, you do physical assessment, while in medical diagnosis, you do more, such as radiological investigations and laboratory tests. I think Mr. Anozie told us that in his organization, physiotherapists don't write the request, say, for radiological investigations or laboratory tests. I think if I heard well, they go through the physician or the doctor, and he writes, and they get the result interpreted, and the physiotherapist will read it. But with BPT now, the physiotherapist has been empowered because there are courses on radiological investigations and interpretations, courses on laboratory tests, and how you can use that to help you with your own physical diagnosis or with ruling out medical diagnosis. And therefore, that's not what differentiates between medical diagnosis and physical diagnosis. The assessments that you do, no. That's not what differentiates them. What differentiates them is that at the end of the process, you establish an organic pathology as the reason for the condition that the patient has. Injury or disease, the source is an organic pathology, and we're going to define organic pathology. And in physical diagnosis, after going through the process, similar to what the medical doctor went through to make a medical diagnosis, because organic pathology established at the end, medical diagnosis is done by a medical doctor, a physician, or medical doctor, generally whatever specialty, orthopedic surgeons, neurologists, and what have you. But with a physical diagnosis, a type of diagnosis that a physiotherapist will make, doing the same process, comparing signs, symptoms, and risk factors, mostly from the neuromusculoskeletal domain, to establish movement dysfunction or movement impairment classification, because we are movement specialists. We are movement specialists. And therefore, our physical diagnosis is about establishing that there is a movement dysfunction or movement impairment classification. This is the only difference. They establish organic pathology as a medical diagnosis. Physiotherapists establish physical diagnosis through identifying the presence of movement dysfunction or impairment classification. And therefore, in the process, you can request for a radiological investigation. You can look at it and interpret it from the perspective of rehabilitation, perspective of physiotherapy. Because radiologists, and I'm not saying will know how to interpret radiological investigations more than radiologists. That's not what I'm saying. What I'm saying is that the perspective they look at is the perspective of organic pathology. There are medical doctors, there are physicians that help, the radiologists help the physician or other medical doctors to identify the presence of an organic pathology, because that is what their scope of practice is. There is a stroke. Is there blood in the mass of the brain? Is there any blockage in the vessel? All these are organic pathology. Is there a breakage in a bone? Is there a discontinuity in a soft tissue? These are all organic pathologies. But I want to treat a patient that has a fracture. For them, it's about fixing the fracture. For me, it's about mobilizing and helping the patient to ambulate after it has been reduced. Its closeness to a joint, how does it affect movement? These are some things that I would be interested in. But to the physician, it is about how do I reduce it? So is it a place that is complicated when it comes to reduce? Or is it a place that will be simple to reduce? What drug do I give to make sure this blood leaves that place where it's accumulated? But for me, I'm looking at the muscles, for example, to be able to see if it is something that I can be able to build its capacity, or if it has gone, that even if I give exercises, it's not going to build up. I remember a patient that came recently, I referred them to musculoskeletal physiotherapist. They were supposed to go for a surgery. And the surgeon said, well, look, there is an indication. Come, let's have the surgery. But the physiotherapist, musculoskeletal physiotherapist, looked at the x-ray and said, look, do you see this muscle? From our knowledge of muscles, no matter how much I build this muscle, it's not going to help maintain the function. Therefore, if they do the surgery, after the surgery, you are not going to go back and have function. And what are you after? Is it to relieve pain? The surgery, is it to relieve pain? No. Is it to relieve any other symptom? No. It's for me to be able to move, to do activities of daily living. I'm letting you know that this muscle is not going to have that. And therefore, the prognosis for able to identify that. The physician was not able to identify that because what they are after is the organic pathology. It's not about the ambulation. And that was very interesting to me. And the patient was convinced. Went back to see the physician, had a discussion with the physician, and the physician also saw it from the orthopedic surgeon, saw the case from the perspective of the physiotherapist, which he did not have or she did not have. So it's very important. You can't be able to make a request, but you are looking at what's relevant to your practice, while the physician or the medical doctor is looking at the X-ray or CT or MRI from the perspective of organic pathology. You are looking at it from the perspective of movement dysfunction. So you can do that. Can do that. So differential diagnosis is about differentiating between probability of one disease versus that of the other disease with similar symptoms that could account for illness or disease in a patient. So this patient comes, is presented. Remember, I told you, there is what is called a diagnostic criteria. You can have two patients having very similar conditions or very similar presentations. Because in two conditions, you can have similar symptoms appearing in the two conditions. But what is it that makes this a diagnosis that is different from the other is what is called diagnostic criteria. So there are some symptoms and signs that you see in this, but you don't see in the other. That set of symptoms and signs. I've given an example severally with Parkinson's disease. So when you can see tremor in other conditions, and you will still see tremor in patients that have Parkinson's disease. You can have slowness in movement for whatever reason in different conditions. But whenever you see bradykinesia, you see tremor, you see rigidity. You can have rigidity in other conditions. But it doesn't come together with bradykinesia and tremor and postural problems. This combination is a unique combination. There's another condition here. It has bradykinesia, but no postural problems, no tremor, no rigidity. You can have a third condition. In that condition, you have postural problems, but you don't have the other three. So meaning you can have symptoms across conditions, But those 4 are cardinal signs of Parkinson's disease. And therefore, when you see those 4, that is what makes the diagnosis Parkinson's disease. And then the other one, you will look for its diagnostic criteria, and you say that, well, because of this unique combination of symptoms and signs, this is the condition. Remember, I keep telling you that I keep using example of medical diagnosis because that is what we are very much familiar with. That's what we have read in school, in textbooks. But now that we're having these workshops, especially the one on human movement system, we are going to learn about physical diagnosis. How do we make physical diagnosis? What are the indicators? What do we see to say the physical diagnosis is this and not this? I give you examples during the clinical reasoning class from that APTA template. And I said there are many more, which we are going to discuss under the course Human Movement System, or under the workshop Human Movement System. So but I am giving these medical examples, medical diagnosis as examples, because that's the one we are familiar with, looking at the symptoms and the way the diagnostic criteria is presented. So this is very important to understand these definitions: diagnosis, medical diagnosis, physical diagnosis, and differential diagnosis. Now, what is an organic pathology? A health condition in which there's an observable and measurable disease present, such as inflammation or tissue damage. So when you have the matter of the brain, through it, fluid, the CSF, oozes out and get deposited between the matter, because there are 3, dura mater, pia mater, and arachnoid. So between any of the 2, if you have fluid oozes out and it accumulates in there, it's an inflammatory problem. So it's an organic pathology. It's not a movement impairment issue. It is an organic pathology. When you have tissue damage, the bone breaks, the ligament tears, tendon tears. All this tissue damage, organic pathology. What do you do to confirm the problem? You do a medical diagnosis. And that is within the domain or the scope of practice of the medical doctor or the physician or whatever specialty. It is detectable physical and biochemical changes within the cells, validated using biomarkers. That's why when you do some tests, you see those biomarkers change, and you see this an indication that there is a lipid profile change. So in the blood, there is this, there is that, and this means there is this condition, which is an organic pathology. Impairment classification or movement dysfunction. Identified clusters of signs, symptoms, symptom-related behavior, and other data from the patient history. Testing used to confirm or rule out the presence of physiotherapy problem, which is movement impairment. Kinesiopathologic model explains the occurrence of movement impairment system. Now, what is the body of knowledge of the physiotherapist? It's kinesiopathology or pathokinesiology. What is the difference between the two? In kinesiopathology, you are looking at movement impairment leading to a pathology. So someone that sits for a very prolonged period as a driver, does a long journey every single day, Lagos to Calabar, Lagos to Kano. Every day he's on the road, he sits there, it's not ergonomics. It is a movement problem. It's a kinesiological problem. But at some point, it leads into opening of the annulus fibrosus, and the nucleus pulposus oozes out, and it compresses the nerve root. And then the patient begins to have pain in the lower back or radiates to the lower limb. This is a movement-related problem that leads into a pathology. And it is expected that there should be a physical diagnosis by the physiotherapist. There should be treatment by the physiotherapist because the movement related is what led to the pathology. If you refer the case to a physician, a medical doctor, that medical doctor is going to treat the pathology, but the cause of the problem will still remain, and the patient will continue to take drugs, or you continue to do surgery, and the patient will not be discharged because the source of the problem is movement related. And therefore, the primary health professional that should first see the patient, make a physical diagnosis, then refer the case to a physician is the physiotherapist. Because it's kinesiopathological model. The movement impairment is the cause. The pathological one is the result of the cause. But when you have the pathokinesiological model, you have the pathology sets in, the organic pathology sets in. And because of the organic pathology, it now leads into a movement impairment. An example, you have Port's disease. Particles, foreign body in the spine. You have Koch disease, microorganisms in the chest. Any of the pathologies, microorganisms, a virus, a bacteria, whatever it is that gets into the body, this is the pathology. As a result of that, the patient will lose functioning, movement in the lower limbs. If it is Port's disease, if it is Koch disease, you lose the ability to move the respiratory muscles to be able to help in taking air into the body. So it's the organic pathology. You have a breakage in the leg. Because of that, you can't walk. It's the breakage, which is an organic pathology. And therefore, the primary person that should handle the cause should be the physician. Therefore, the physician should make a medical diagnosis dealing with the organic pathology and then refer the case to a physiotherapist to deal with the movement impairment after making a physical diagnosis. So for physiotherapists, what is key is what is called the human movement system. And this is what I said we are going to deal with in a workshop to come later. The human movement system is a physiological system of systems. They call it system of system. So physiological systems that interact to produce motion of the body and its parts. You have the muscles. They are the effectors. So they are the effectors. They are the ones that contract to move a bone at a joint for movement to take place. But that is the end product of the system. Neurological system is the one that regulates the movement, because it's through the neurological system that you even think of the movement, you agree you are going to move, and you now plan the movement. The muscles only move because the cells in the brain send impulses to the muscles and ask them to contract, and then the movement will take place. And therefore, you have the effector and you have the controller or the regulator. The two of them form part of the human movement system. But of course, you have those that support them. The pulmonary system, the cardiovascular system. Without oxygen, the muscles will not contract. The brain will not regulate because they need oxygen to do that. Without the cardiovascular system, blood go into the lungs to take the oxygen to the brain and to the muscles. Nothing is going to happen. And that is why we have cardiovascular physiotherapy, pulmonary physiotherapy, musculoskeletal physiotherapy, neurological physiotherapy. Of course, there's also integumentary. Let's not also forget that there is the endocrine system, because all those chemical reactions will require something from the endocrine system for the reactions to take place, for oxygen to be used, and all that. And therefore, it's a diverse area. because all of them take care of me, because I deal with organic pathology. Therapist, because I deal with organic pathology. No. I'm a cardiovascular physiotherapist because cardiovascular system contributes towards having movement. And even within the cardiovascular system, we are looking at how movement-related issues take place. For example, the heart has muscles, and it is those muscles that contract to pump blood out or bring it back. And therefore, it's movement. The lungs don't just bring air into the system. The muscles of respiration work, and it's a movement. So this is why we are there, because there is movement in those systems. And what we do is to restore those movements if they are abnormal or if they are lost. So that is why we have the human movement system, and the APTA in 2013, designated the human movement system as the identity of the physiotherapist. If you don't understand the human movement system, then you are lost as a physio. And that is why we keep making diagnosis that is medical diagnosis. And I keep saying, you can't impress anyone if you speak to them about what they know more about than yourself. You will impress people if you talk to them about things that they don't know, and they will be mesmerized and they will be listening to you. So you go to the ward and you're trying to talk about stroke. That's medical diagnosis. They know it more than you. Want to talk about Parkinson's disease? Talk to them about the human movement system, about how the muscles contract to bring about movement, about how the brain controls the movement, and things like that. And come and see how they will pay attention, and they will see you as an autonomous profession. That when they are referring, they will say, please, for your expert care, not that, please, give this patient this type of intervention or that type of intervention, because you don't really show them that you know more than them. But the moment you do that, they will salute you. And next time, they will invite you to sit on the same table to discuss a case with them, because there is something they don't know and they need you to educate them. So I want to admonish us, let's focus on our identity. And let's not begin to go into others' scope of practice. We'll just get lost there and we'll lose our identity. Why is it important for us to screen patients medically? Number one, I've mentioned direct access. If patients come to you directly and they have an underlying disease that you are not able to identify, and you continue to treat them for weeks until that underlying disease that had very minimal symptoms begin to have worrisome symptoms, you will be in trouble. And even if you are not in trouble physically, morally, you would have aided them to create a bigger problem for themselves, because you cannot be able to screen all the systems to know if there are problems that are not within the scope of your practice for you to quickly refer to other professionals. Whatever we treat, the body is a complex system. You have problem in one system, it refers pain to another system. Or they might be independent of each other. The patient comes to you with back pain, but the patient has heart disease. It's an underlying disease. It might not be within the scope of a practice. It is your duty to identify it and refer to the person that is going to treat it. Misdiagnosis and misdiagnosis. Very happy that we have seen that. What Mr. Anozie mentioned was about the issue of an underlying disease. I didn't ask him if the case was referred to him in the first place. If it was a misdiagnosis. So it will be more of a misdiagnosis than an underlying disease. Well, it can still be referred to as underlying disease. But if it was missed, he identified it, referred back. The same thing with that of Mr. Adjol. It was missed, came to him, we find out, and they referred back the patient. Concealment due to fear or embarrassment. The patient was raped. And because of that, they feel, well, I'm not really feeling so much discomfort or pain at the moment. Why do I have to reveal it? Let me just leave it. But your screening is what possibly could lead to them to know that that problem is still there. How is your urination? When you urinate, is there any pain? Oh, yes, there's pain. But just like that, there is no pain. That's why I did not report. Okay, why do you have that pain? Do you know why? Doctor, I didn't want to tell you. But now that you have identified that I have a problem, let me just open up. This is what happened to me. So they conceal it. But the screening will help reveal what they are concealing through questions that lead them to know that even though they are hiding it or they think it's not there, but it's still there. Early signs of diseases. Get them at the early stage, because at the early stage, they are not very worrisome to the patient. Identify them at the early stage. Systemic diseases mimic neuromusculoskeletal diseases or injuries. The case of Mr. Anozi of urological system referring to the musculoskeletal system. The heart can refer to the shoulder. The lungs can refer to the shoulder. The kidney can refer to the back, and so on and so forth. And we are going to see a lot of that as we go through this presentation. Because of yellow and red flags. Yellow flags are those that show caution. So mostly yellow flags, they are risk factors. Usually red flags, combination of risk factors and maybe 1 or 2 symptoms. The moment you see that, quickly refer. But if it's a yellow flag, there's a combination of usually risk factors. You treat with caution, you continue to monitor the patient to see if a symptom will appear. The combination gives a red flag, you quickly refer. Primary healthcare. You find yourself in one locality where there are no physicians. No one is going to screen the medical cases, medical issues. If you can't screen, you will not know if the patient needs to go to the city, to a general hospital. Very important because of primary healthcare to be able to do medical screening. You are not a medical doctor, but you are doing medical screening. But what is your limit? Your limit is that you cannot go ahead and make a medical diagnosis. You only suspect that there may be a medical diagnosis. And you now write, dear physician, refer patient A to you. During my assessments, I observed that the patient had A, B, C, D. You now mention those risk factors or symptoms. And these may indicate the presence of an organic pathology. And therefore, I refer to you for your expert opinion and care. Thank you, Rufai Yusuf Ahmed, neurophysiotherapist. That would be the way I would write it. I'm not going to say, based on my assessment, I've realized that you have misdiagnosed or you have missed the diagnosis. And I think this should be a diagnosis of disease or cerebral palsy or lumbar disc prolapse. And therefore, I want to review your assessment. No. The same way they do to you, you do to them. There's just going to be a lot of chaos in the healthcare system. Therefore, we need to write in a manner that will just say, I have seen indications that there may be an organic pathology, and just refer. Let them be the ones to make the medical diagnosis. You have finished your job. Red flag, risk factors, symptoms, and signs considered by a clinician that leads to strong suspicion of a serious condition or life-threatening disorder that requires additional evaluation by the clinician or another specialist. Yellow flag just indicates the need for caution and further investigation. As we go through taking the system one after the other, we are going to see what indicates a red flag and what indicates a yellow flag. But as I've said, yellow flag, usually there are risk factors. Red flag usually is a combination of risk factors and some symptoms or some signs, but not up to the level possibly of having the diagnostic criteria fulfilled. But even if it is fulfilled, since you are not going to make a diagnosis, it's a red flag, just refer. So we are going to look at screening for neurological diseases. First, the red flags. Any questions or comments at this point before I proceed? Any questions or comments? Yes, Jennifer Eze, are you trying to speak? Yes, I can't hear you. Maybe your network. Yes, Jennifer, are you still there? Dr. Achubwe, let's see if Jennifer can come back. If not, then you will speak. Okay, Dr. Achubwe, Dr. Fine Achubwe, go ahead, please.
Yeah, good morning, everyone. Thank you very much for what you have just, made us to understand so far. My question is specifically on the role of physiotherapists in primary healthcare.
Okay.
Medical diagnosis. In primary healthcare, where there is no physician, go ahead, based on our scope of practice, to screen for medical diagnosis. Now, having established that this case should be referred, I want to just give you one scenario in my place of work. I want to see how it can be handled generally. In primary healthcare, if you refer to a physician, maybe in general hospital, or maybe in tertiary hospital, as the case may be, there will be no problem. There will be no question by the physician. They will gladly, accept the patient and then do the needful. However, if we are within, maybe in tertiary institution where I work, the experience I had some time ago, a case was referred to me, and I did this screening, and I discovered that he had fracture of one of the cervical bones. And I told myself I shouldn't be handling fracture. Yes, he has quadriparesis. But what of the fracture of the neck? A physician should also, handle that. I therefore made a referral to the physician, this time around the orthopedic doctor. And he bluntly refused that as a physiotherapy, I do not have right to refer the case to him. That the person that referred, I should refer back to him. And the individual, the patient is not within the environment, is from a very far area. So those people deem it necessary that because of quadriparesis, physiotherapy should see, and that's why the individual referred. It's from a health center in one of the institution, educational institution, I think Polytechnic as it were. So the patient was rejected, and I had to do what I could do within my scope of practice. And at the end of the day, the patient was not satisfied because of the way the other physician handled him, and so he stopped. In fact, he went to another institution. So, sir, why I brought this is because of what you just said. That we should refer. What happens if we have that kind of scenario, or if you have that kind of scenario in your institution? What should you do?
Wonderful.
So thank you.
Thank you so much, Dr. Fine. And I have to say that Dr. Fine has a DPT. We did DPT together in University of Michigan, Flint. Same set, we finished together, and it's wonderful. You can see from the case, it's someone with experience, and not just the knowledge, but also the practice. And I believe you have the answer. You are just asking so that you will hide the fact that
Yes, I want others to also learn from it. Yeah.
Fact that there are others on the group, yes, I'm going to go ahead and attempt to give a solution. Now, number one, policies drive the actions and the activities of every professional. Policies. I remember I've been saying this on platforms, maybe to a few of you, I may have said it while you were here. I attended a management meeting in a university. I was representing a director then. As a deputy director, I represented a director, and the discussion, usually management meetings, each dean and director will report the case of their faculty or directorate. And when the health director was speaking, after they finished speaking, I now raised my hand and asked the vice chancellor, I said, why is it that there are no physiotherapists in the health center? I said, in the teaching hospital, we receive many patients from the university community. We treat them, but why can't we just have 1 or 2 or 3 employed so that at least instead of coming from the university to the teaching hospital, which is far, at least they can have someone to manage them on cases that can be managed in the health center before a referral is determined. And the health director quickly responded to say that the health service in universities only employ the professionals that are allowed to be in a primary health level. And I was wondering, I said, what makes you feel that a physiotherapist cannot be there? And I referred her to the document, the policy that she was talking about. And I said, what do physiotherapists do? Do assessment, you do prevention, you deal with assessment, you make diagnosis, you treat. In fact, you even go ahead and rehabilitate. And rehabilitation only takes place in the community. And therefore, if they are not there in primary healthcare, who integrate the patients back into their communities? And it was convincing. And from that time, I was also directed that physiotherapists should be taken, because I referred to a policy. And because of that policy, it was agreed that physiotherapists are supposed to be in the health center. And as I speak right now, there are physiotherapists in the health center. Initially, they did not take full time. They said funding issues and whatever. So what they did was to ask the Department of Physiotherapy to select 2 every week that will go there and serve. And then another week, another 2 staff will go there. They will be remunerated. They will see patients. And that's how it started. It's possible now they have taken permanent staff or they have not taken, I don't know. So it's about policy. Now, we just wrote to the minister some times back. We wrote to the minister that we want integration of physiotherapists into the primary healthcare to be institutionalized. We wrote a proposal, sent it to him. The moment it got to him, the coordinating minister of health, he approved. And he now sent it to a director and said, go ahead and begin implementation. As I speak right now, we have started working with the primary healthcare authority, primary healthcare agency, to be able to work out the modalities for how we can set rehabilitation to be integrated into the primary healthcare. And I think this is where we need to come to. Because whatever that person did was an individualized case. Go and ask him to bring any policy that says he shouldn't. He will not bring any policy. If another person that has a better understanding or has some form of stability emotionally and sentimentally, they will accept it. I have experienced such. But the issue now is for you to understand the current laws and the current rules. Look at the curriculum. If there is no document on scope of practice, look at the curriculum. What have we been taught? Even if there is no policy, there is no law. Let's start from there. Pick the curriculum for DPT and you have done DPT. Pick the curriculum for BPT. You have done BPT. Look at it. What does it say about your capacity to be able to do what you did? Then search for policies. Get the primary healthcare policy, get the National Health Act, get so many of those policies, sit down, study them, then extract and then you now challenge the person, of course, with a very good approach. If that doesn't work, I will tell you something. It's a responsibility on you to make sure that patients don't have that gap within the multidisciplinary approach to treatment. If they have that gap, that fracture you are talking about could lead to death. And it's a responsibility on you to make sure you go through the processes that will avoid other patients coming to be delayed from having the services. If you are a head of department, you are a member of management. Even if you are not a head of department, there must be a channel. Is it cervical? Is it directly to the CMAC? Or how do you want to first start with the individual, sit with them and talk to them? If they can't listen, they are head of department. You must have an approach. But number one is to get those policies and the regulations and your curriculum and your scope of practice, and you now present the facts. They must accept it. If they don't accept it, it is on them, not on you. But the struggle should continue. You can refer the case to a regulatory body, either their own or your own, because it's part of the regulation professionalism. If a case should be received, if it is not received, it is unprofessional. And his license can be withdrawn by his regulatory body. Why did the government change that rule? That if there is an accident or gunshot, when people go to the hospital, they were not receiving them. But now it is a policy of government that they should be received and treated immediately, notwithstanding what caused the gunshot. Even if it is an armed robber, he was shot, you go there. There is a policy that explains what should happen. So I think we need to familiarize with those policies. We need to understand how to go through advocacies. I'm doing a master's in public health now, and I see a lot of those things. And I think possibly we need to begin to have workshops and trainings on those. How do we understand, get them? How do we even identify the policies? How do we familiarize ourselves with them? How do we use them in advocacies and other matters relating to professionalism in the health sector? So these are just a few things that I can think of in my mind. Primarily the issue of the policies, understanding them and making use of them to advocate and push for the right thing to be done. But I don't know if there's anyone that has any other different view or any additions to what we can do in a situation like this. Thank you.
Thank you, Prof. You have answered very correctly. I think that should be the way to go. So maybe others can also lend their voice. Thank you, sir.
Thank you. Thank you so much, Dr. Fine. And please, as we go through, Dr. Fine, whenever you want to contribute and help us, please just jump right in. I think the next one we'll do will invite you, because I know this is an area that you are very familiar with. We'll invite you as a resource person very soon. Yes, Mr. Anozie, go ahead.
Yeah, can I just chip in something? Because you mentioned about policies and all that. We know that in the different health sectors, there are a lot of bureaucracy that does not really favor patients. And sometimes also the pattern of referral, the tone of, the language used, in referral can also trigger some people who are not, who are not really patient-oriented to act in an unprofessional manner. So it is very important from my experience, the way we write our referral letters, you have to be very diplomatic, especially when you come into a place where there is bureaucracy and there is political, and some people have that undertone that you don't know your onions and you are not supposed to be in that place. But if you communicate well to them, like writing, like I like the way Prof has been mentioning about not like telling the patient, the doctor that, oh, I think this patient is having maybe cancer of this area or something like that. But when you write that, oh, I've reviewed and I've identified some things that's suggestive of this, could you kindly review this patient as this, and that? It presents you more like a professional who understands his own boundaries and scope of practice, and they may be able to undertake that. However, I've seen some cases where even if you write very well, they still are sort of stubborn about it and say, why are you supposed to refer to me and all that? I've seen a situation where in when I was in neurosurgery ward and I had written to the consultant involved that there's a problem. I don't think we can mobilize this patient based on the protocols. This patient is still within like 4 days post craniotomy, and from the protocols I have and from my training, you are not supposed to get the patient out, you know, out of bed immediately. So, and the response was really bad. It was more like so bad, by writing. Even though I wrote well, I feel like within myself. So I made it, I gave myself a point of duty to actually approach the consultant and everything. And I say, I'm discussing this patient. And I brought it in a particular way. I said, this patient has had this. I know this is our plan, your plan, and everything. But this is what I have studied, and these evidences have shown that if you do this, and I gave my reasons why this patient would not be mobilized. Can we just wait till this patient has gotten through this phase? Then we can gradually approach. And I told him what I will be doing in the interim now, because I realized that there was a pressure of, quick ambulation. Let's just ambulate this patient out. But by the time I discussed more about the risk associated with this premature ambulation, I was able to see reasons with me. I was able to solve that problem. So communications amongst professionals is one thing that may really, really affect us. I think we need to be doing a lot of communication training, communication skills. There are verbal and non-verbal communication skills. Sometimes, even if you write, sometimes they don't see. But when you communicate verbally and make it an effort, then this multidisciplinary team approach will be imbibed. Because I see a situation where someone is telling, what do you know? What training have you passed through? Because they are not able to swallow the fact that we are knowledgeable enough to know, identify red flags and yellow flags, like you have been mentioning, and all that. So that's number one. Then number two again is that in those places when you now know that the patient's safety is at stake, that no matter what I think, if I have done those things I have done and I'm trying to resolve the conflict, interprofessional conflict, and it's not so, and the patient's safety is at hand and everything, I would need to escalate it to the highest order. I would really write, I would involve my supervisor, I will involve everybody, I will copy everybody that's involved, and I will raise it to the extent that this person is now really, really not acting in a professional manner, and patient safety is involved now. So I will do that, because if I don't do that, it means I'm not responsible enough to act in the best interest of my patients. So I think it's really an issue that we need to discuss, because most times you find out that everybody, for instance, you go to the ICU, you have done your chest percussions for your patient, and obviously you now need that. You find out that this patient is finding it difficult to expectorate, and you just speak to the nurses in the ICU there and say, please, can you kindly sanction this patient? This time that this patient is, they'll just tell you, are you teaching me my work? And because you are in a place where physiotherapists will have not working in the ICU may have not been given that power to suction patients or trained to suction patients there, but you know that this patient requires suctioning at this point. It causes a lot of trouble and everything. Sometimes you really have to raise your voices eventually and involve a lot of people before they do that. But I think I don't want to really prolong this matter, but it's very sensitive, especially when we want to have interprofessional communication. So if there's a way we can make a uniform approach so that every member of the multidisciplinary team will be involved to have a meeting, like a regular meeting where the patient's preferences are discussed, the goals of treatment are discussed on a multidisciplinary level. It will also help to, straighten out these communication problems that we have. Thank you.
Okay, thank you very much. That's another very good one. While you were speaking, you said two things that made me now to think of another thing that I missed while I was speaking. Number one, you talked about the bureaucracy. Number two, you talked about them looking at the capacity. Now, do you have the capacity to send directly to a specialist? Because if you look at the way specialists operate, someone would have sieved the cases and said that, okay, this is a case that needs to go to a specialist. And therefore, if they don't know if that capacity is there, the fear will be that everyone is just going to send a case to an orthopedic surgeon, to a neurosurgeon, and then the neurosurgeon will sit and begin to work towards it, and then realize that it is not a case that it even needs to go to them. It should have gone to the GOPD, where a physician will just handle the organic pathology before it goes to them. So I think even though we are talking of policies, we are talking of looking at enforcement and advocacies and all that, we need to also look at the situation in its merit. We need to do a lot of awareness. We need to let people know what capacities we have, because that is what is going to make them to feel at ease, that if we refer to them directly, they feel they can sit and look at it, that it's at the end going to be their own case. They are not going to waste time and then send it back to a general physician. So I think there's a lot to do. We can continue to discuss this, and we will continue to bring in ideas. We'll give them excuses, we'll give ourselves excuses, and that is what is important in life. Don't just look at things from your own perspective. You need to also look at the perspective of the other professional. And that is what beautifies the issue of multidisciplinary approach to patient management, or interdisciplinary or transdisciplinary, as the case may be. Thank you so much. These are really interesting discussions. Yes, Mr. Sondi.
Thank you, sir. I want to appreciate you for this presentation, sir.
Thank you.
When you were trying to reply the former speaker that just spoke, I deduced some certain observations, sir.
Okay.
I observed that probably that may be peculiar to some institution where some individual or institution may not have the boldness of having that, that screening principle, or let me say the screening skill to deduce when they should refer or when they should not refer. However, there are some certain challenges some institutions are having. Let's take, for example, in our own institution, we have such a challenge before in the past, but not now. That when you refer cases or condition to a neurosurgeon or orthopedics or whatever, somehow they feel they are the one that has the prerogative of referring patients to other specialty areas, not the other way around. These are some of the problems the institutions are facing. But over the years, we have been able to solve that telling them that we too can refer cases to them. And before we got to that level, not that we just did it overnight, but we're able to prove to them that we have that capacity to refer cases to them. Let's say, for example, there are some cases where they make some diagnosis and they make it wrongly. We came in, we reversed that diagnosis, and they equally align with it. So all these are equally some of those capacity which you made mention of. If an institution or the therapist or whatever does not have that competence in order to ascertain its professionalism, the neurosurgeon, or let me generalize it, the so-called medical doctors will be looking down on such specialty, especially physiotherapy this time around, then they will not be able to honor any referral or justifications to agree with them for making a referral to them. But at ICU, I want to believe our physiotherapy have established our stand to the extent that with suction, if you don't have the competence of having how to suction in the first instance, the need of saying you are calling a nurse to come and help you to suction where you see the need for suctioning such a patient, I want to believe is an aberration to us as well. If there's not any of such capacity, I think we can restructure that and let the narrative change. So physiotherapy can suction. I had experience when I was in JOS, even as intern, as least as intern to that level. I had a case that lasted for almost 3 months. That case is a case of head injury. And the patient was almost dying. And I got to a level as an intern, I did not know what to do at a particular level. But then, for the little experience I gathered so far, either at the undergraduate level, and when I went to the institution doing my internship, I draw an inference from my HOD. And from there, I made a decision that there was a time I was going to call him into the case. And I later informed him, I informed my upline. And when we went to the ward, guess what we saw? The patient in question, what was we called to come and ascertain the patient dead. And it's coincidental, sat at the patient dead, at the nurse's desk, writing to confirm the patient is dead. And we got in, and I said, sir, I presented the case to my HOD, and including his assistants, we came together, we were 3. And we saw this case. My HOD now asked, he said, is there any suction machine here? I said, yes. That was the first time I had experience of how to suction because of that exposure I had. Now the HOD said, okay, bring the suction machine. He didn't even call the nurses. He didn't call anybody. So I said, we have in this ward. And I went straight to the suction machine. I brought it. And he told his assistant that, please open this patient up. And then he started doing the suctioning and was doing chest physio. Before they knew what was going on, the patient came alive. Before I left JOS, that patient walked and drove back home. So these are instances where you establish your stand and there's nobody that can turn it down. When you know what you are doing, from there, my HOD taught me a lot of things. And this is a person of Dr. Onowe I'm talking of. So he was the one who taught me a lot of things. He taught us so many things that I'm using today to practice. And we have equally, by extension, when I came to OETC, and we're able to equally use some of those things, and the skill is there. And we establish our own stand, including all the physiotherapists in OETC. We suction and without necessarily calling the nurses. Then we make referral, and none of our, though in the past it used to be turned down. Of course, again, the issue of turning down a referral, being referred by physiotherapy to medical doctor, I had that experience too in JOS, but our HOD changed the narrative. So I think in individual institutions, we can let our stand be known and let us put in the professional skill in which I want to, which you are doing presently, and everybody is actually applauding your efforts. And this is some of those things that can expose us and give us the apart from policy, you said, policy alone will not give us the confidence, will not give us even the platform alone, but skill, professionalism, and which is part of your domain that you have spread out for us to explore. So these are things that can give us and establish our stance in our practice at different institutions. Let's not say that whether we have capacity. That's area what I'm just trying to point out. Not that we don't have we have the capacity, but we just have to prove it. But when you're talking of capacity in terms of numbers of physiotherapy, in terms of those on ground in individual institutions, probably some who have actually treated this Japa syndrome, we may end up having low profile professor in terms of a cadre, that the cadre that may be available at institutions, they may be at the level of NYC, from NYC below. But in the situation where we have senior therapists and above that can put in the skill and teach the junior ones some of those things that is expected, though individual institutions too again may be have some certain policies which you may want to be restraining them, but then our professionalism will speak volume and our competence. Thank you, sir.
Thank you. Thank you so much. Thanks a lot. Two things before the next people that raise their hands speak. Number one, I know there are times that we have the capacity to do some things, but there are other professionals also that have been trained to do that. So usually that's the multidisciplinary approach to things. So we need to look at what is it that we can ask others to do, what is it that others can do. It has to be us that can do it. So just that as a comment. Then secondly, I agree with you that policies enough will not help us. I agree very strongly. And I want to continue to admonish us to continue to update our knowledge, but also skills, so that we can be able to confront all these challenges and the issues of not knowing our identities and not knowing our capacities and things like that. I want to admonish us to continue. I'm a registrar, but every week, at least I participate in at least 2 workshops every single week. Either I'm the facilitator or I'm a participant. Every week, at least 2. And so that I will not forget the skills. I volunteered in National Hospital, since I'm in Abuja, to serve as a staff pro bono. I treat patients there in National Hospital. I also teach in Chrisland University and Kaduna State University pro bono, so that I don't forget the skills. And I think it's important for us, especially those that are in the system fully as clinicians or academicians, to continue to update selves, looking at the knowledge and the skill, and also progressively moving from one level of skill to another. We need to even plan how to develop ourselves. And that is why you'll see in the MRTB domains, you'll see that there's a 5th one that is not part of the ones that we do about how to develop ourselves. We learn even how to do that. And it's very, very important for us to continue to do that from what has just been said. Thank you so much. Please, if you can lower your hand. Mr. Anozie, please, let's try to be brief because we have a lot of slides to look at. That is why we have it today, on Wednesday, next Saturday, and next Wednesday. We can't cover because we did this systems review during DPT. It's a semester course for almost 12 weeks. Every single week we take lectures, not less than 2 hours. And we read materials, we do things. So there's no way we can cover all that in just 4 days of lecture. So we have a lot really to cover. Yes, Mr. Anozie, please go ahead.
Yeah, thank you very much. I just wanted to mention the fact that, the last speaker talked about suctioning, and I understand that some physiotherapists have that competencies in suctioning. But from the undergraduate level, when you are taught chest physiotherapy, is mentioned, but practically most students are not being taught to suction properly, even during our clinical rotations. So if some people have learned, the HOD who taught you how to suction, and you become competent and you're now able to do it and everything, but it has not been made uniform, then it's a problem. The problem we're having is that we need to all have uniform competencies. As if you are coming out as DPT, which I feel that DPT will do for us, we all have that basic ones. Then specialty-wise, if you are going into as a cardiopulmonary physiotherapist, you should have that suctioning. You should be able to also use some high-level respiratory devices to be able to manage patients. So in a place where you now know that this is not within your competencies, and as a professional, you are not supposed to do things, within your competency level, outside your competency level. So, and you have a nurse, you have the knowledge that this thing has to be done, and you just need to communicate, and it is not done. I think there's also a problem. So the problem is not that we just want to encroach and go beyond our own competencies. If it is within the curriculum and our competencies, obviously we would do that. But in a place where basically you've not had that competency and you know that this is important for your patient and you have discussed this and you are met with a very negative attitude towards that patient, I think it's important that we still need to escalate that. It doesn't make you less of the fact that you recognize that this patient requires this, but I'm not competent enough, still makes you a professional to do that. But I also want to plead with the professor, to ensure uniformity of competencies in the undergraduate levels. You can see that some people who graduated, they said people who graduated in the north, they have hands-on skills better in neurology. They will say people who graduated in the east, they have hands-on skills in respiratory. I've seen things like that happen, and you see interns performing differently because of their background. So if we're able to uniformize competencies, I think it's going to go a long way to help us. Thank you very much.
Well done. Thank you very much. Dr. Jibril Samani, either you Hafiz, whoever is with us, please take note of this discussion so that we'll see whatever is we can put as part of our next workshops. We'll include them, and then maybe we'll make a submission to MRTV just to see how these issues can get into our curriculum. Because that's the only way we can make it uniform, just as requested. Thank you. That's a good one. If you're in here, Ugochukwu, so please let it be brief so that we can proceed with the slides. Okay, if you are not close by, can we have Olutumise Akonde?
Okay. Good morning, Prof.
If you're in here, okay, go ahead. Yes, thank you.
Yeah. Good morning, Prof. Can you hear me, sir?
Yes, we can hear you. Go ahead. We can hear you.
Okay. Thank you so much for thus far you have taken us into this very educative workshop. Yes, I just want to say something about based on what one of us read here about us doing a lot of things in the world, especially without waiting for I think he made mention of nurses. And one of the things he made mention or he said was issue of sunshoning. Okay. Yeah. Was a few days ago I had a similar discussion with some of my colleagues about having an oxygen cylinder, in the department in case of any emergencies. Okay. I mean, administer an oxygen therapy, to a patient in case something happens that requires such services. And now the argument was, yes, it's a nice, I was the one that raised it anyway. Like, we are supposed to have something like this because patient comes from ward, we bring patients from ward to the department to manage and all that. But you can never predict what might happen, have had similar experiences in the past. So, but now the argument was that, are we really trained to handle this? I mean, is it in our scope of practice to administer oxygen to a patient? How many people knows if we go by it, as we requested for it from the hospital and one was brought, how many people knows how to, the technical know-how. So on that drive, so I recall that when I had one of us here mentioned things about sunshine. So in conclusion, I think we have to look at these minor things, which are very also essential for us maybe, like you said, we can include it boldly, because I don't believe we can just do things because we feel we can do it, but we have to look at it very well, know whether it's enshrined into our scope of practice. Then if that be, then we can fashion out maybe 2 workshops, or I think you should know best way to handle it, on how to establish it and carry everybody along. Take colleagues through that part so that we can actually learn it and know how to go about it, if such issues arise. Thank you so much, sir. Yeah, thank you, Prof. I'm done.
Okay, thank you very much. That's another very, very, very good one, because it's not just about my capacity, ability, or skill to do something, but is it within the scope of practice? And luckily, now the government has adopted the tax sharing, task shifting policy. What that means is that if the society needs a skill, and those that would have the scope of practice to do that are not available to do it, another professional can be trained to do that thing. The principle is that the patient should not lack that just because the professional is not there in that community to do it. And recently, I was a member of a committee, or I was invited to be part of the committee on national policy on prescription and dispensing. And what happens in the UK, it's been adopted here in Nigeria because of the task shifting, tax sharing policy that the government has adopted. And very soon, you are going to see policies coming up that allow you as a physiotherapist to do some of these things that are not naturally within or traditionally within the scope of practice of the physiotherapist. So when the policies are there, then the next thing is training. And then you can be able to do it. Where those professionals are not there, or they don't have enough time and hands to be able to do those services. So I think it's very good for us to consider this. And that's why when the discussion was going on, I said, Hafiz and Dr. Jibril Samani should please take note of these issues. Let's submit to the board. And therefore, the board is an institution. The registrar is just an individual that might be there today, might not be there tomorrow. So if there is a submission that is formal, and then it goes through the institution, then whoever is there or is not there, this thing will continue to be there as a policy that the country can use. And I assure you that when this submission is made, we'll look at it and we'll see what is within the scope of practice. We'll quickly start training. What is not within the scope of practice, we'll have to take it through this government policy on tax shifting, tax sharing, so that we get the approval, and then we'll now begin to train, either centrally through the curriculum, or as we do workshops like this one. Policies first, then training. Scope of practice can be widened. Okay, wonderful. We'll continue to consider all this until we get to where we want to get to. Yes, Olutunmise Akonde. Okay, are you there? Or should we... Okay, yes, go ahead. Go ahead.
Yes, thank you very much for this beautiful presentation. I have 3 observations, and I wish I wouldn't want to take much of our time. Number one, our interpersonal relationship with our medical colleagues too is important. Yes. Because many a time, because of this type of knowledge that we are having now, many people, just as you have said about referral, they will just, in fact, they will have mentioned the case to the doctor. So that's why I want to applaud the way that you mentioned it, that with these findings from risk factors, from this, and I am seeing this as red flags, I wish you could review the patient and take up for expert review and management. That's the language. A number of our colleagues will have mentioned the diagnosis to the doctor, who will be angry. You know, that's why they see us as a threat. The reason why doctors don't want us to have doctor of physiotherapy is that we want to take up the issue of medical diagnosis from them. That is one of the reasons they think. And I always explain to them, even at my KIDAT, directory KIDAT, that every profession is evolving. In the 90s, when we were in school, we have a little bit of this idea that we are talking about. However, it's not as elaborate as this. And we should have a dynamic mindset to put it into practice and to let them, but the way and manner we communicate matters too. However, not all of them, they don't know physiotherapy, and we'll continue to educate them, and we'll try to see how we can, interpersonal skills matter a lot. That's number one. Number two, there's I don't know how you are going to do it, registrar. There are a set of, I want to choose my word because I belong to them too. But all along the line, I've been learning and learning and learning. There are a set of physiotherapists that our younger ones we meet online that have, this is the way we've been doing it, and who told you that? How will you be doing things like this? I want to encourage every one of us, whether younger generation, so that younger generation will not be poor for, and the older generation too will learn, will continue to relearn and unlearn, and as the profession is dynamic. Because a number of times when you have good mind and your guy is not having that, sometimes especially as lower cadre, you may want to listen to your guy until you are able to supply so many papers and things to convince him that this is the evidence-based practice or how things are done now. So the younger one too should know how to present it so that it will not be as if you are condemning your guy. That's number two. Number three, I want to draw our attention to something that when we are learning all this, it's important to know that when we want to practice it, we should take into cognizance the society and the environment that we are. So that, like, there was a case of a physiotherapist I took up that asked a patient to stop drug. That is physiotherapy that the patient need. It's not in our jurisdiction to influence medication. We can advise. Like, I'm a neurophysiotherapist. If you prescribe a drug whose side effect is drowsiness, I can write to you that I want this patient to be active, and wish you could review the patient, and so that the patient will be active. It's not me that will be telling the doctor the prescription. How can you tell a patient to stop taking drug all because you say it's not helping the patient? So by the time the patient gets back to the doctor and he told the doctor, the physiotherapist said I should stop taking drug, I have to come in, appeal to the doctor and rebuke the physiotherapist that we don't practice like that. That's an infraction. Even when you have one opinion or the other with respect to the care of another person, there's a way you relate, you suggest. Even if you have a you query, you suggest. Suggestion can be looked into. Though we have some people that are adamant that even though when you are reaching out to them, they'll say, this is how I've been doing my thing, and let's reach out. But let's be careful on how we reach out. Let's be careful so that all this knowledge we are acquiring will not make us to be condemning what others are doing. I like your word that you said we don't say you have misdiagnosed the patient. The medical diagnosis is not our primary assignment, it's doctor's assignment.
Seems the network is bad from your end, possibly, or is it from my end?
Yes, Prof, I am done. Thank you very much.
Okay, wonderful. Thank you so much. I agree with you fully, and this is why it's important for us to open up and speak, because you can say things that I will not say, and I myself will benefit from some of those things. So please, I want to make a request. All those that spoke, I remember Mr. Anozie, Mr. Sunday, There's one other person, I can't remember the name, Mr. Akande also. Please, can you reach out all those that, yes, Mr. Fine Achube, I have your contact. Please, can all those that spoke reach out to Dr. Samani? Please, let's have your contact, because as we are doing this, no man is an island. Yes, Mr. Ifeanyi, exactly. No man is an island of knowledge. And if we want to diversify, we want to have this reach many places, then many people need to come on board. One person cannot make an impact that a group will make. So please reach out to Dr. Samani so that as we continue to move, we can begin to decentralize this. Let's have these lectures in zones and also at many times, so that if you want to join this one, you join. If you can't join this one, you join that one. That way the message will pass across much, much more. Thank you so much to all of you. I appreciate all the discussions. Yes, I think the issue of diagnosis, not agreeing with him, you may not know what type of diagnosis possibly he's referring to, because we don't do medical diagnosis. And I think I emphasize that a lot. We don't make medical diagnosis, but we make physical diagnosis. So we make diagnosis, but it's a physical diagnosis, not a medical diagnosis. I can't remember the context in which that was mentioned, but I just want to say this, that we make diagnosis, but we make physical diagnosis, not medical diagnosis. So if anyone says we don't make diagnosis at all, or we don't make physical diagnosis, then that's wrong. But if they say we don't make medical diagnosis, I agree very strongly. We can only suspect that the medical diagnosis is present and we refer. So that's it. Okay, physical diagnosis. No, we make physical diagnosis, definitely. And I'm going to deal with this in that workshop on human movement system, how we can make the medical diagnosis. Dr. Samani, please try to send let them know how they can be able to reach you. Yes, okay, the number is his WhatsApp number is there. Please, any other person that has not spoken but that understand this concept, because it's only people that have spoken that will be able to understand their level of understanding of these concepts. People that have not spoken that you can contribute, please to reach out to. It's not just limited to. So thank you so much. Let's proceed.
Doctor,
Screening of the neurological system. Usually we say neuromusculoskeletal
Somebody wants
system
to
when we
speak,
talk
I
about
think.
diagnosis. Sorry?
It's like someone wants to speak, but maybe the person stopped.
Okay.
Had somebody trying to speak.
Maybe at a later time.
Yes.
Yeah. So although the neurological system, we do physical diagnosis there, but you can have a physical diagnosis within the neurological system, but you can also have an organic pathology. So what we are looking at here is not the physical diagnosis. So henceforth, whatever you see is about suspicion of an organic pathology that will require referral, or if it's a red flag, or if it is a yellow flag, that we need to be cautious and make sure that we follow up the patient to ensure that if there is need for referral, we make the referral. If there is no need for referral, at least we'll be at ease that we don't have any cause for alarm. So what are those things that are regarded as red flags in the neurological system? That the moment you see that, you need to refer. What are those things? And this is where Dr. Jibril, you and Hafiz will help us, ask you to pick those things. But what you are going to do is to look at any assessment that is not a traditional assessment that physiotherapists do. So if, for example, we say blood pressure, pulse rate, and things that are really very commonly done by physiotherapists in Nigeria, I don't think we need to include those, but there are other things that you're going to see that are not commonly done. These are the ones that we need to take note of so that we can have a workshop where we can train people on how to do them, because your ability to identify a red flag will depend on your ability to do the assessments and interpret the assessments to mean that there is a red flag or to show that there is a red flag are very important. So number one, uncontrolled seizure for more than 5 minutes. So if someone has it for 1 minute, it might be seen, it might not be a red flag. It 2 minutes might not be a red flag. Or if it comes and it can be controlled. If it comes and it can be controlled, especially if the patient possibly has been diagnosed and they are on medication, the seizure comes, they take their drug, or they get any medication or anything is done to them that controls it, then that is not a red flag. But if it is uncontrolled and it persists for more than 5 minutes, so usually you have that when there is an intracranial tumor, and this is a situation that is called status epilepticus. So when you have that, it is an organic pathology and it is a red flag, you need to refer. So a patient comes to you, you are treating the patient begins to have the seizures, and then it's not controlled and it gets to 5 minutes or more, just refer that patient immediately. When there is loss of consciousness, whenever a patient loses consciousness, it's a red flag. It means there is an organic pathology. Or when the person is difficult to arouse. Now you have to now differentiate that between people that naturally they are difficult to arouse. But you can pour water on them, you can beat them, you can drop them off from the bed and they will not wake up. That is normal, but a person that is easy to arouse, that now becomes very difficult to arouse, is a red flag. It requires a referral. Extreme confusion that is not consistent with premorbid status. There are some people that get easily confused. You see them. Sometimes you ridicule them, you laugh at them, but it's natural to them. So that is why you are looking at the premorbid status. You ask the relatives, is what I'm seeing in this patient a common thing even before he had these symptoms that brought you to the hospital? So if the premorbid status was a status of confusion, may not be a red flag, but if it is not, and it is an extreme confusion, then it is a red flag. There is an organic pathology. Signs of acute infection. Now, acute of infection, either you have a fever or chills, things like that, or when you have pain in a particular area that's coming with fever and the patient is shivering, is feeling cold. These are signs of acute infection. And those signs of acute infection associated with neurological signs. So maybe the neck is rigid, there's nuchal rigidity, or there is localized back pain. So nuchal rigidity, localized back pain, and the patient has signs of fever. Together, they show that there is an infection affecting the neurological system. It is a red flag, you refer. If you look at all the ones that I've mentioned, remember what I said about red flag. It is not just risk factors. It's either a combination of risk factors and symptoms or signs, or even if you can't see any risk factor, the symptom and signs can form a red flag. But when we go to yellow flag, you will hardly see symptoms and signs come together to form a yellow flag. So signs of acute infection. But there is also neurological signs, nuchal rigidity, localized back pain, and you have fevers, you have chills, and other signs that there is an acute infection. This is a red flag. When you have signs of spinal column instability, so when there is decrease in motor or sensory status, so you have in the upper limb, you have weakness, and you have abnormal tactile sensation, for example, when the patient changes position. When the patient is standing, the sensation and the strength of the muscles are different from when the patient is lying down or sitting down. So these are signs of spinal column instability. So in anyone that has had a cause, say there was trauma, there was anything that could lead to spinal column instability, and the patient reports with muscle weakness or abnormal sensation, and you ask them, this muscle weakness or this abnormal sensation, does it change with change in position, and they say, yes, this is a red flag because it shows possibility of a spinal column instability. When there is rapid onset of focal neurological deficits, rapid onset, so within seconds or minutes, you have the weakness reaches maximum that could be achieved. So complete, just comes within seconds or minutes. So no, no, it doesn't give you any signs that it will come later. Rapid onset, and it's focal. So in your upper limb or in your lower limb, neurological deficits, and that could be muscles or sensation. It just comes, and you have abnormal sensation or just have weakness without any notice. That's what I was trying to look for. There's no notice that sign or symptom is coming, and it's neurological. It's a deficit. These are signs of stroke. The moment you see that, it's a case for referral. When you have non-responsive autonomic dysreflexia, so you are treating a patient, measure the BP. Before you finish treatment, you did not give any exercises that will lead into a high increase in the BP. You measure the BP again, and suddenly it has increased. Especially in patients that have spinal cord injury below the level of T6. So patients like that usually have non-responsive autonomic dysreflexia. This is a red flag. It's a case for referral. As I've said, especially if it is in a patient that have spinal cord injury below the level of T6. So any of your patients that have spinal cord injury below the level of T6, try to take the BP at intervals to be able to see if there is a sudden change in the blood pressure. That is a case for referral. When there are signs of spinal cord compression, so neck or back pain, remember earlier we talked about localized back pain. So when you have back pain or neck pain, but also you have bowel or bladder dysfunction. So you ask patients about the bowel, frequency of voiding, and other symptoms of bowel dysfunction, bladder dysfunction, the urination, whether they can hold it, they can't hold it, and other things that have to do with bladder dysfunction. You have neck pain or back pain, and you have bowel or bladder dysfunction, and then there are sensory or motor changes. All this put together, when you see them, show the possibility of spinal cord compression, and this is a red flag, you quickly refer. When there are signs of elevated intracranial pressure, so what shows that there is an elevated transcranial pressure? So Dr. Samani, these are some of the things that we need to take note of, the issues of how do we assess bowel dysfunction and bladder dysfunction. Of course, sensory and motor changes, we can include them because sometimes they are not routine. Because I know I've done workshop where I will ask people, how do you assess for proprioception? How do you assess for vibration sense? How do you assess tactile sensation? Is simple. I think many people can do that. Temperature, people know how to do it, but I hardly go to hospitals and I see test tubes and maybe warm water and cold water aside that people use to do those assessments. There are some things, 2-point discrimination, things like that. These are sensory modalities. We don't usually assess them. For the motor, it's simple. We always use the Oxford grading system to do assessments. So what is important is for us to be able to know how do we do the tests, because that's the first step. Remember when we did evidence-based practice, we looked at 6 components of patient management. You can make a diagnosis, physical diagnosis, or you can suspect the presence of an organic pathology if you don't do 2 things. You need to know how to assess and what to assess. And this is what we discussed in the second lecture on clinical reasoning. How do we even know what to assess? We talked about the analytical cognitive process and the non-analytical cognitive process. And we said this can form a stable system. How do we continue to add to our vocabulary of symptoms and signs and risk factors? We discussed metacognition. So I assessed this patient, and I could only remember to take the BP. I only remembered to look at the motor assessment and some few other ones. And then I now go back and sit down after the patient has gone. I say, under neurological disease, what are those red flags? Then I will say, oh, look, I did not ask for bladder and bowel dysfunction. I did not ask them about visual loss or mental status or nausea and vomiting. Oh, these are important ones, because if that patient has spinal cord compression, I wouldn't know, because sensory and motor changes alone will not tell me that. I should have asked the patient about the bowel and bladder dysfunction, because my interpretation, which is evaluation. Now, if you look at what we are doing now, it's majorly evaluation. Majorly evaluation. So for people that did not understand what evaluation was when we did evidence-based practice, this is typically evaluation. But can you do evaluation without knowing what assessment to do? Can you do evaluation without doing the assessment properly and getting the appropriate response? You can't. And therefore, all these are important. So neck, back pain, bowel bladder dysfunction, sensory motor changes, put together gives an evaluation or an interpretation that helps us to know whether there are signs of spinal cord compression. Then signs of elevated intracranial pressure. When the intracranial pressure is elevated, this is just a statement. But practically, realistically in the clinic, what do we see what do we do? And how do we interpret that to know that there is an elevated intracranial pressure? So when the patient reports headache, and therefore in our history, the patient says, I have headache. Altered mental status, that is when we do our TPP. So whenever the patient has their orientation in time or in person or in place is altered, these are some of the things that we see as signs of altered mental status. It could be our assessments of consciousness, the GCS. It could be the mini mental state examination or Montreal cognitive assessment that we'll do that will lead. So please, I'll put down altered mental status. It's something that we think we know we do, but usually we don't do it fully to be able to know for sure that there is an altered mental status, because there are different domains. If you only assess one or two domains and the patient's altered mental status is in another domain, then you will not be able to know if there is an altered mental status. It's only those domains that you have assessed that you'll be able to report. So it's important for us to look holistically at altered mental status. How do you assess altered mental status? Nausea/vomiting. Ask the patient, you feel like vomiting or do you vomit? Visual loss. This is part of every neurological assessment. And this visual loss, is it that the patient can't see at all? Or is it that the patient can't see clearly? And therefore, Snellen's chart is there. I want to see that. Anyway, there's a difference between visual loss and acuity. So the patient can't see. But there's also issues of visual acuity. That's where you use the Snellen's chart. Or when the patient sees double, it's not all the time that patients will report this. And that is why in screening, you ask them, he has headache, altered mental status. You follow up with the questions. Do you have any nausea? Have you been vomiting? Can he see very well? Ask the relative. Can he see? Can you see? Can you see? When you look at objects, do you see them double? Then the Cushing's triad, decreased heart rate. So you take the heart rate. These are vital signs. And someone said this is why they are called vital. Therefore, they are vital because they will help you to know red flags that you refer. If not, the patient will collapse, and at the end of the day, they may die by your feet. So the heart rate decreases, the respiration is irregular, and the pulse pressure is high. So when you have a case, headache, altered mental status, nausea, vomiting, when you take the blood pressure of the person, they are systolic and diastolic. The difference between them, if the difference increase in that difference, so we know what's normal. So usually you will have one can go high, one can go low. So that difference, if it's high, you have high pulse pressure. That also is part of what indicates signs of elevated, or what indicates elevated intracranial pressure. So all these things are important. Do we assess all of them? I don't think so. Must we be medical doctors to assess all these things? No. We are physiotherapists. Are we trying to diagnose that there is intracranial pressure increase or elevation? No. All we want to do is to suspect so that we immediately refer the patient to the physician. So it's important for us. I know we can ask about headache. As I've said, we are going to do altered mental status. For nausea and vomiting, it's easy. Visual loss, we ask. Diplopia, we ask. But decreased heart rate, we measure. Irregular respiration, we measure. Increased impulse pressure, we measure. So all those things that we need to measure, and they are not really common, please take note of them because we are going to do them in the practical or the hands-on. Now, these are yellow flags. When we see them, we don't have to refer immediately, but we need to continue to monitor the patient to see if they've developed yellow flag from them. When there is progressive neurological signs, in a patient that is known to have, to be non-degenerative neurological condition. So it's a non-degenerative neurological condition. It's not degenerative. So maybe it's progressive. So the patient has neurological signs. So, but now there are progressive neurological signs. But the patient does not have non-degenerative, it's a non-degenerative neurological condition. So meaning there's a neurological condition. Let's say someone has TIA. What is expected of that patient? It's non-degenerative. It continues to get better. It's non-degenerative. When you have Parkinson's disease, the condition continues to get worse. The neurological signs continue to progress. But when you have TIA, you're expecting the weakness or the sensory affectation to continue to get better. And in that particular patient, the condition begins to get worse. That is a yellow flag. Why is it not a red flag? Because there are a number of reasons why a case that should continue to get better will get worse. It could be temporary thing. The person just gets fever, but the temperature has not increased, or maybe the patient gets fatigued. A number of reasons. That is why it is not a red flag. You don't just begin to refer. Now, can you see where the case of the specialist will now be thinking, should I accept this case from you? Or should I ask you to send it to a physician that understands the concept of red flag and yellow flag? Because if you send a yellow flag to him, he will think you have wasted his time because this is not a case that has reached a point that he should see. That is what he will think. But if he sees that case and he considers it as a yellow flag, he has helped the patient. But where the problem is that there are so many patients, they can't see anyone but him. In that hospital, he is the only neurologist. But there are over 10 general doctors in the GOPD. They can see as many as possible, but for him, he can only see 10 in a day. And because there are so many referrals, many of them yellow flags, they all come to his desk, there are 50. By the time he sees 5 and they are all yellow flags, things that a common general doctor will see, he would have missed the chance to see those specialist cases that have already gone into the level of red flag that he knows it is his case. He needs to make a diagnosis there. So our ability, like someone said, is not only the policy. And I think maybe because I was discussing with Dr. Fana Achubwe that I know has done DPT, has been practicing it, possibly for him, I'll say, well, he knows that. But for someone that does not know the difference between a red flag and a yellow flag, you might see a yellow flag and you now refer to a specialist. The specialist will just feel you have wasted their time because they are still going to refer back to a general person and say, please continue to monitor until it gets to red flag before this case is referred to. So it's very important to understand the concepts of red flag and yellow flag. When do I refer? When do I continue to monitor? And what do I continue to monitor? So if a patient has TIA and I see progressive neurological signs, I'm going to begin to find out why is this weakness progressing instead of getting better. I'll find out. Does the patient has fever? Because when you have a fever, it's not that the brain is not sending the impulses, but the body is not reacting to it because of the fever. When a patient is fatigued, it's not that the brain is not sending the impulses to the muscles, but the muscles are just tired. They will not continue to contract and move because they are tired. So a number of reasons. So when we rule out those cases and we still see the progressive neurological signs, and maybe we now see other symptoms that form part of the diagnostic criteria of an organic pathology disease, then at that point we'll say this is a red flag, and then we'll refer. So when we have signs of undiagnosed motor neuron disease, for example, you have fasciculation. So you have an organic pathology. Usually, for example, you have polio. I mean, we don't talk about polio now. I don't think many people talk about polio, but as an example, it's an organic pathology because it's a microorganism gets into the anterior horn cells and affects it. When you have polio or you have any disease or injury that affects the anterior horn cells, you are going to have fasciculation. Fasciculation, if you have seen a ram or cow slaughtered and peeled, the skin is peeled, you see the muscle twitching. For people that have gone to the abattoir, you see the muscles twitching. That is dead, but you just see the muscle shaking. So that's fasciculation. So you see that in the muscle, affectation of the anterior horn cells usually, but it can come in other motor neuron diseases. When you have fasciculation, you have atrophy, you have weakness. So put together, you continue to monitor, but you don't have to refer immediately. You continue to monitor to see if you see more signs that there is an organic pathology. When you have bulbar and cranial nerve signs, so please take note of this. Take note of this. I think fascicular atrophy, I don't think we need to assess atrophy, even though many people only look at the muscle. You don't measure it. But I think even measuring atrophy, I think it's a common thing by physiotherapists. You have a landmark, you measure to the bulk where you want to see the bulk of the muscle. You now take the tape and you put it around and you see in centimeters or inches, and then you compare with the other side, or you compare over time to see whether there is increase in the bulkiness of the muscle. With weakness, that's not a problem because we assess using Oxford grading system very often, and I think that's not an issue. But bulbar and cranial nerve signs, these are things that we need to do practically. We need to do them practically. So when you have bulbar and cranial nerve signs, the patient has difficulty swallowing. So if you have any of the bulbar and cranial nerve signs, it's important to ask about others. So when the patient reports difficulties swallowing, sometimes you have to ask, depending on where the disease is. For example, those in neuro, that's what is called syndromes. You have monoplegia, you have hemiplegia, you have paraplegia, you have quadriplegia. You can have affectation at the level of cerebrum. You can have affectation at this level of brainstem. You can have affectation at the level of the upper part of the spinal cord, the cervical spinal cord. And all this may give you similar presentations. So when do you expect to have bulbar and cranial nerve signs? Because in the lower limb, you can have a hemiplegia, but the cause is at the level of the upper part of the spinal cord. But the injury only affects one side, and it's not in the brain. But when do you now begin to ask questions about bulbar and cranial nerve signs? When the problem is at the level of the brainstem and above, you can have bulbar and cranial nerve signs. And therefore, any patient that you see signs that the brainstem and above is affected, ask them questions like this. Dysarthria, swallowing difficulty, hoarse voice, visual changes, nystagmus, ptosis. Nystagmus, when you look at the eye of the person, you can see, keep looking at my finger, and then you keep looking at the eyes. If there is nystagmus, you'll see the eye oscillating a little bit. It will be oscillating and shaking. This is something that has to do with what is called visuo-ocular, vestibulo-ocular, the vestibulo-ocular system. Usually the vestibular system and the visual system, they work together to maintain gaze on an object. So if you have a vestibular problem, then you are going to have a problem with the ocular system maintaining the gaze, because the vestibular system is the one that controls the eyes remaining on the object. Just like it controls the eyes moving, because the eye usually moves faster than the head. And therefore, when it gets to the object, it can overshoot before the head gets there. It is the vestibular system that helps the eyes to counter-rotate so that it focuses on the object. So usually when you see nystagmus, it's when there is a vestibular problem, not controlling the ocular system. So then ptosis, so the eyes move, not facing where they need to face. Involuntary movements or tremor. So all these bulbar and cranial nerve signs, there is a thought, it's a yellow flag. There might be an organic pathology, but you continue to look at what could be, what could come for there to be an indication of a red flag. Because an organic pathology, you either have an infection, so if you have an infection in the brain, or you have fluid moving from where it is to where it's not supposed to be, or you have blood oozing out, or you have a number of those things put together with these signs will now graduate it from a yellow flag to a red flag. When you have involuntary movements or tremor, my father, when you see his hand as he sits, you'll see it shaking. And I've known him from the time I was very little. At some point in my life, I had that. But I've never had any other symptoms that show that I may have Parkinson's disease. The same thing with my father. He has never been diagnosed as having Parkinson's disease. At over 70, we have been to the hospital and said this tremor. In fact, we went to India at some point that he was sick and said, please, can we look at this, his tremor? They said it's not Parkinson's disease. It's not any of related neurological disease. It's normal. but it's there. So you can't just see the tremor and you say this person has an organic pathology, he has a Parkinson's disease. I suspect that he has a Parkinson's disease, let me refer. No, you need to continue to monitor the patient. The moment you see another sign coming in, he now begins to have bradykinesia. He wants to do this, and he becomes very slow. So can we add the Unified Parkinson's Disease Rating Scale as part of what we'll do? Because that will help us to be able to know, apart from the tremor, how do we assess rigidity? How do we assess bradykinesia? How do we assess postural adjustments? So that when we see after the tremor, we see one or two more, it now becomes a cause for concern, and we refer. But just seeing the tremor alone, without any other thing, it means we need to do more assessment, or we need to continue to monitor the patient. That is a yellow flag. Constant headache, increasing over time. You can't just say that there is an organic pathology. You need to follow up the patient. Do they eat well? Do they have anxiety as a result of something worrying them? Do they have any problems at work? What exactly is it that would make them to have? Because there are times that you don't eat, you keep walking, you don't rest, you don't sleep, you'll have constant headache. It's natural. All you need to do is to counsel the patient. Look, relax, eat, rest, leave this work, so that the headache will go. And therefore, it's just a yellow flag. You need to be cautious. Must you refer the patient? No. You refer the patient, has headache, and the doctor now asks him questions. Have you eaten? He said, no. Have you rested? No. For 2 days, I've not had good sleep. He will return it to you and say, look, please don't waste my time. Next time, don't just say constant headache to me and say you think they have a migraine. Changes in personality or cognitive status. Just like that, there are times that people will just get confused because of shock. But the moment they relax and you remove them from the environment, you find out that their personality comes back to normal and the cognitive status comes back to normal. So you don't just refer just because personality changes or cognitive status changes. You need to follow up to see what are the possible causes. Are they natural causes that can, the trigger can be removed? And when that is done, that's it. Or maybe possibly some people will take something, and by the time its effect goes, they come back to their normal status. So you need to make further investigations to know what causes it. Maybe it's just transient because of a trigger. You remove the trigger and you don't have to refer. Vertebral artery insufficiency, vertigo, dizziness, nausea, vomiting. We have talked about this one's head and neck pain. I think these ones are straightforward things. The only thing is that we need to ask about them. Patient comes to you thinking you only do, Mikel Onkwasa, what do you call it? Someone, I think when I taught in Chrisland, they told me in Yoruba what they say, bend and extend. That's what some people think you do. Why should they begin to tell you about nausea or vomiting, even if they have it? So if you don't ask, they will not tell you. And therefore, the key to knowing if there is suspicion of vertebral artery insufficiency, sometimes you see one, then you now go ahead and ask others. So vertigo, dizziness, nausea, vomiting, head and neck pain. Put together, the interpretation or the evaluation is that there may be a presence of vertebral artery insufficiency. Neurological signs inconsistent with diagnosis. So you have a diagnosis. So there is a diagnosis that came to you, this medical diagnosis. But you are seeing neurological signs that are not consistent with that diagnosis. So you need to look further. Where are their inconsistencies? Is it because there are other underlying problems? If there are none, then we now write back and say, we have seen the referral with this diagnosis, but based on the assessment, there are these signs that we feel may not be consistent with the situation of the patient, and therefore, then you'll do a referral. Signs of systemic illness. When do you have a systemic illness? So these are the interpretation. This is the interpretation. The patient has fever, but how do you know the patient has fever? You need to assess. The temperature, very important. You can't just say this patient is feverish. Assess the temperature. So we need to have those gadgets. Diaphoretic, profuse sweating. The patient is sweating. There is AC, the patient is sweating, and the patient does not look that he's anxious from running away from someone that's going to kill them. Because that's when someone follow you with a dagger. When you enter this place, there is AC. You will sit down and you'll be sweating. No signs of those, but the patient is sweating profusely. Systemic illness. Poor exercise tolerance. You are trying to give exercise to the patient. So these things that we are talking about, it's not just at the point of assessment that you see a yellow or red flag and you make a decision. It is very possible that you have already completed your assessment. You are treating the patient. Then you observe that the patient is sweating profusely. You have given them exercise, but their exercise tolerance now, let's add this. How do we assess exercise tolerance? Very important. How do we assess exercise tolerance? So the patient, you not assess their temperature. Add that too. How do we assess fever? Profuse sweating is something that's obvious. You just observe the sweat, patient's face, forehead, or wherever, and you'll be able to know. So all this put together, what is the interpretation? The interpretation is that there are signs of systemic illness. You need to then begin to find out further. What systemic illness is it? Is the patient on drug? So you don't just refer. You realize that the patient has an illness that it has already been diagnosed. The patient is on drug. Oh, yesterday I went to hospital. Feel the fever since yesterday, and I've gotten drug. So that's just a yellow flag. You leave them. The only thing is that you continue to monitor them. Is the drug they are taking care of the symptoms within the period that is expected? If not, then you now begin to think if there is another systemic illness, not the one that is being managed, so that you can now refer back. So the patient has informed us that they're taking their drugs, but over this period, they have not been getting better, they have been getting worse. And from all our assessment, we can't think of any other reason why the symptoms persist even after taking drugs, and therefore we are referring. So what we have had is on neurological system. And we have seen red flags, we have seen yellow flags. Red flag, the moment you see that, refer. Yellow flag, when you see that, you need to make other observations before you decide if there is need for referral or if you continue to keep the patient. Another thing very important that we have seen is the fact that for you to be able to do this, you need to, one, know what to assess. You need to know how to assess, and you need to know how to interpret. So these three things are vital. Therefore, we need to go back and read our risk factors, symptoms, and signs of diseases. Then we really need to upgrade our skills of assessing those risk factors, symptoms, and signs of diseases. Then we'll now use this information for interpretation. Therefore, when the patient comes, we assess. It's one thing to assess, it's another thing to know what to do with what you have assessed. And that is the interpretation, that is the evaluation, and that is what many physiotherapists do not do properly. So I don't know if we are going to take any comments or questions before we proceed to the pulmonary disease. If there is any comment or question, please feel free.
Hello, sir.
Yes, go ahead. Go ahead, Mr. Sunday.
Okay, thank you, sir. I want to appreciate you, sir. The lecture has been well educated. So the issue of, for example, the issue of pot disease that is being suspected.
Mm-hmm.
If you suspect, let's say, pot disease, I just want to is there any area we can refer it as a red flag? The patient is coming to physiotherapy for the first time and is in first contact. Because it is one of the conditions over the years that personally I've observed that physiotherapy may miss. Probably the person may be informed somebody is having back pain. And the person comes to the physiotherapy and physiotherapy now make assessment and equally align that it is back pain and begin to manage. But meanwhile, the condition that is predisposing the patient to back pain is pot disease. It does not show any much symptoms. They only complaining back pain and the patient okay, but probably after assessment and all that, is decide to go on with some of probably heat modality or whatever. And the condition begin to get worse. Can you please put more light on some of the areas where it could be diagnosed or having red flag? And then appropriate referral is made so that that patient is not being mismanaged. We have had instances anyway that there is a case we had in our center that was referred to us. But that condition was being managed by a medical doctor. The doctor placed the patient on drugs, but it was not an anti-cough drugs. They managed the patient for almost 3 months or thereabouts. But incidentally, the patient just tumbled to see physiotherapy. Immediately, physiotherapy saw that there was a gibbous at the back. And he said he won't do anything. We actually commend that physiotherapy for that bold step. He made some suggestion to the patient. Please, go back to your doctor or go to the teaching hospital and let them do properly the diagnosis. That he is suspecting this condition that it may not necessarily be back pain you are having. It's only that it's a symptom. But I'm suspecting this. And lo and behold, when the patient went and he came back, it was diagnosed to have pot disease. I want you to please put more lights to this because it's not all physiotherapy that could have able to get that exact fact, diagnose and be precise and make appropriate fact. The patient came back with paraplegia. We are even still battling with the situation now. What? Hello, sir.
Yes, I think your network is breaking, but I think I've got your message. And now when you talk of pot disease, I think when I mentioned pot disease at the point of differentiating between kinesiopathological model and pathokinesiological model. And I gave that as an example so that it would be very specific. But if you look at all the red flags and the yellow flags we looked at under neurological disease, you realize that there is nowhere that they mentioned a particular condition. And therefore, as a physiotherapist, you are not referring the suspicion of a particular condition to a physician. That's not what you are doing. What you are doing is to refer the suspicion of the presence of an organic pathology. That is where you'll see where they said in a known non-degenerative condition. Non-degenerative conditions are many, And all other places, you'll see that they are looking at systemic disease. There are many systemic diseases, horse disease included. But because you are not referring to the physician with the suspicion of a condition, no, you are referring with the suspicion of an organic pathology. And therefore, if there is any signs there is infection, if there are any signs that the fluid has moved and is compressing the neurological system, that is why they talked about intracranial pressure increase or elevation. They are not talking of any particular condition. They also talked about systemic signs of systemic diseases. So all these are terminologies that are showing to us. Don't bother yourself. Don't go and take yourself to the extent that you have to narrow down to a particular condition, suspecting the condition before you refer. You don't need to bother yourself. That is the responsibility of the physician, to go and continue to rule in and rule out until he gets to the suspicion of a condition, and then he confirms that medical condition. But for us, the moment we see signs that there is a systemic disease, the moment we see signs that there is increase in intracranial pressure, whatever the condition that brings increase in intracranial pressure is a referral case for us. It's up to them. Let them go and find out which of the conditions is there. Systemic disease, there is an infection affecting the system. It doesn't matter what condition affects the system. It's organic pathology, not within our scope of practice. Refer it. So we are trying to find out if there is the presence of an organic pathology. We are not trying to find out if there is a presence of a particular medical condition. We don't have to get to that. But if we are able to, that's fine. We can advance and know that. But the goal is not to know the condition. The goal is to know that there is an organic pathology. Whatever organic pathology it is, it doesn't matter. It is not within the scope of our practice. It will not affect our referral. In as much as there is an organic pathology and we suspect strongly it's there, it's a red flag, let's quickly refer. So I hope that helps. But if you have any counter motion to this, feel free at a later time, you raise it, or if any other person wants to add to this, please feel free. Mr. Anozie.
Thank you very much, Prof. You really clarified a lot of things. However, I want you to throw more light on the yellow flags, because I saw that when you talked about the yellow flags, you mentioned about the bulbar affectation. And I know that my patients who have had bulbar affectation, from my little experience, they also present with dyspnea. So, and if patients are having dyspnea, sometimes if you now check their oxygen saturation, you notice that it has gone down to, unacceptable levels. Sometimes you even get the patient who is having SpO2 less than 88%. So, at that point, even though it's regarded as a yellow flag, would you need to regard it as a red flag there, even though it's a bulbar affectation, then because they will have difficulty swallowing, this dyspnea they have. But I also noticed that people who have difficulty swallowing are also struggling with dyspnea. So they will breathlessness, which will lead to when they're having that hypoventilation, they are now having reduced oxygen saturation, which we know that if we don't address that it can, affect multiple organs, and a lot of problems could come up from that. So at that point, I don't know whether I will still regard that as a red flag or yellow flag. Then you also mentioned the fact that For yellow flags, you monitor. You monitor and, to see the changes. But for instance, for a progressive condition where you know that, oh, you've discovered that this is progressive, are there like outcome measures or something that will tell you how this patient is now drifting from a yellow flag to a red flag and all that? And what period of time would you have to monitor these yellow flags? And so that we don't, because I understand the fact that if the patient has a yellow flag, you may communicate with their directly to their own GP, not specialists, while you co-manage with the patient. But how long, what is the time frame between for the monitoring? Then how do you,
Okay.
yes, the thin line between the yellow flag and the red flag in some cases. Thank you.
Thank you very much. Now, see, that's why these workshops that we're having are very strongly interconnected, very, very strongly interconnected. You can see that as I discuss one, I refer to one. The clinical reasoning and decision-making class that we had on Wednesday. Unfortunately, because we had only 3 hours, we were not able to digest the clinical decision-making as part. But for those that joined, you remember there were some attributes of the task that we discussed. And one of them was certainty. That for you to be able to make a decision, having enough information will determine how fast you make a decision. And that was more or less a theory. Can you see we are bringing it into reality now? Seeing examples that are clinical. In the red flag, you have enough information to be able to be certain that the suspicion of an organic pathology is there, and therefore you refer. But in a yellow flag, there is high level of uncertainty. And what does that mean? It means you don't have enough information. You need to gather more information to make it a red flag. Now, when you talk of bulbar and those cranial nerve signs, let me give you an example. If something very serious happens and someone gets into a state of shock, the person cannot even, they open their mouth, but the words cannot come out. But is that an organic pathology? It is not. It is a temporary thing. The moment the person relaxes and they get back their attention, the shock ends. They now begin to talk. Okay, this is what happened, this is what happened, this is what happened. They will now start, if there's someone that talks too much, say, look at this guy. When the thing happened, you open your mouth, no word came out. So will you say that person has dysphagia or they have? So there is only one thing, it's not enough. You need to now wait and see. So how long will you wait to see the cause? There was another thing that we saw. Let me go back to the slides so that I can be able to give example. Yes, I've talked of the issue of progressive neurological signs. That I said, look, this person has TIA. It has been diagnosed. We know it is because it says known non-degenerative neurological condition. That's an example, the TIA. It's supposed to continue to get better. But this person now, so now, I will now begin to find out, is there fatigue? And what's the reason of the fatigue? Is it because the guy walked from home, very long distance, came down, asked him to do exercise. The muscles are sore. He cannot be able to do the exercise. It wouldn't take me long to confirm something like that. But the person got in shock. They couldn't, and the movement seems to be even getting worse than getting better. We now found out about that. Is there any reason that is not organic in nature? For example, a muscle, a nerve was compressed. It's possible the person sat and the nerve was compressed, and temporarily the muscle power now even reduced instead of being increased. But by the time the patient rests and that nerve compression temporarily now is relieved, then the movement will now come back to the normal, and instead of getting worse, it now begins to get better after the treatment that you give to the patient. So these are all things that you don't have enough information. You want to build the information. Now, what determines when it becomes a red flag? It's about the issue of taking the red flag, then seeing the little you have out of all this information in the red flag and the yellow flag. How long does it take you to get all the information that makes it a red flag? That is what determines how long it takes to get a red flag and refer. Because there are so many red flags, each one will have something different. So let's say go back to the red flag. So this is a red flag. You have the one that has this signs of spinal cord compression. You only have neck and back pain, and you have sensory and motor changes. But there was no bowel and bladder dysfunction. I won't call that spinal cord compression, because even without spinal cord compression, you can have neck or back pain, and you can have sensory and motor changes. All this could be that the patient had a problem in their cerebrum. It can give this. But so let's say if that patient has had a problem in the cerebrum, is being managed, but then he fell and then now has spinal cord compression. He has been managed for the brain injury. Is there any need for referral? No, because he's been managed for it. He's on drugs, he's been managed, rehabilitation, all that. But he said, I fell down. The sensory and motor, now, have they increased? Now, if they have increased, it's beyond the other one being managed. There is no bowel and bladder dysfunction. Then this is just a yellow flag. But the moment we now realize we didn't ask about bowel and bladder, oh, let me come back and ask. There is bowel and bladder. At that point, even if it is 1 hour or just 1D, in between knowing that the patient has neck pain, back pain, sensory or motor changes, and after 1 day you now realize that there is bowel and bladder dysfunction, at that point, you already have gotten a red flag, because the missing information that makes the situation uncertain has now been provided. So it all depends on at what point that missing information that makes it a red flag is gotten. The moment you get it, it now completes complete information, certainty has increased, referral should be made.
Yeah,
Yes,
thank you very much, sir.
Thank you, yes. Okay. Ifeanyi, go ahead, please. Sorry, if I pick the name that I can pronounce well, pardon me that I don't pick the first or the last name. I just pick the one that, because my eyes can't see well. So the moment I see the capital letters, I just call that one. I need glasses, and up till now, I've not been able to go and get glasses. So
no problem. No problem, Prof. No
Yes.
problem, Prof. I think you know me better with honesty favor. I think that's what you know.
Okay, I see. That's wonderful.
All right,
Oh,
sir.
you're honesty.
Yes, it's me, sir.
I didn't know. Okay, that's
okay.
great. Wonderful. Well done.
All right, sir. Yeah, thank you so much, Prof, once again. I think I don't know about others, but I love the way this workshop is going. You know, it's really touching a lot of gray areas. Yeah, it's really touching a lot of things that we should know as a physiotherapist. The truth is that the room lectures that most of us had didn't cover a lot of things that at least basically you should cover. And that is why these workshops are very important to complement a lot of things, especially in the course of our practice. Yeah, so thank you, sir. And now what I want to chip in is concerning the referral. You know, you mentioned, I think it's a very important thing for us, because the truth is that most physiotherapists doesn't take it serious to refer patients. You know, yeah, they will either, you know, continue managing as okay, so far these things I will manage are there. Maybe I'm managing to improve the muscle power, I'm managing to improve skin sensation. You're managing to, based on what you are managing. But there is a need for you to refer. Okay, I had an experience. He's a private patient, one of my private patients. He's a stroke patient. Man is being diagnosed with CVA. So I've been seeing the man, and he is doing well. But for like 3 days, was not able to see him. Okay, based on their own arrangement, it wasn't my fault. So on the fourth day or fifth day, they called me that the man had seizures. They didn't know what it is, but they explained. I said, okay, no problem. Let's see. But how is the man now? I asked them how is he? They say he's fine. He's now okay. He's doing well. I said, no problem. Let's see if anything of such will happen again. Then after some days, they called again that it happened again. I said, okay, I will try and come and see the man. Let me just see him physically to know I'm coming, that I will come. So when on the day I went there, I saw the man. He was sitting down and he was fine, very, very stable. And I was, having a chat with him and all that. And all of a sudden, while I was there, he just coughed. He coughed, something like coughed. And no, he sneezed. Yeah, he sneezed. And immediately he sneezed, he started checking, And I found out that this is a seizure. The man started having seizures again, right there in my presence. So managed to put him on bed and then try to position him well. Luckily he was able to calm down again. I mean, the seizures, man was able to calm down again. And after that, I told them immediately that they're going back to the hospital, that he needs to be taken immediately to the hospital. So they made arrangements and moved the man immediately. Just within a few minutes, they are up to the hospital. And when they reached there, the first thing the doctor, because they called me, that they were so happy, like, you told us. So the man mentioned, he says seizures. That's exactly what you said. I said, no problem. But the most important thing is let him be taken care of. So finally, they are back and the man is doing well again. And they even told them there that he needs to continue seeing a physiotherapist. I said, that's fine. So what I'm trying to say is that it's assuming I said, okay, don't go to the hospital. It's fine. Let's continue, treatment. Who knows, something that's unprofessional anyway. But if something happens, it might even lead to medical legal issues or whatever. So it's very important that we are treating that issue here. And again, before I round up, I really want to bring this to your notice that even if we didn't exhaust what we have today, okay, we can reschedule and let's not rush it, because these things, taking it step by step, these things are very important issues. So we can reschedule. Even if we need to pay again for the time, we can do that. But let's continue this way. It's really helping us. Thank you so much, sir.
It's all right. Thank you so much. Well done. So you talked about the decision, the medical legal, and things like that. So if we look at this, even if there is a problem, we don't pray for that. But if there's a problem, it's our justification. And this is evidence-based. Said if you have A, B, C, it's a red flag, quickly refer. But if you have A, continue to monitor. So it's like an SOP. It's like a clinical guideline. You are following it. You see ABC. Now you record. Maybe in the patient's home you have something that you used to record. You record. I've seen ABC. Now refer. But I just see A and B. I will refer. Even if something happens, and we don't pray that it happens, whoever comes and look at the record, they will see that the guideline says if you see AB, follow up, even without referral. So just because a patient has seizure, doesn't mean we must refer. No, because the guideline says if it is uncontrolled and it lasts for over 5 minutes, it's a red flag, quickly refer. But it is not up to 5 minutes, or it is controlled, even if it is up to 5 minutes, you find out that now there is something that you have asked to do after that. You do that. If anything's happened at the end, you find out that you followed a rule, you follow a guideline. It might even be possible that it is not because of that decision not to refer that something happened to the patient. Because this is what the evidence has shown, that if you see this, follow up. You don't have to refer. But if you see this, you must refer. So it is in that situation, the rule says refer, you have not referred, you are in trouble. So I think having guidelines, having SOPs, having evidence, it helps us to feel relaxed when we take those decisions. And I think it's important for us to go back and complete that clinical decision-making lecture. Because to look at example, the issue of certainty, and there are a number of other attributes that as we practice, we'll be able to see those and we'll be able to apply it in our decision-making, and that is what makes us professionals. Being able to take those decisions that are appropriate based on the knowledge and the skills that we have acquired. Thank you very much. I think in the absence of more hands, we'll start looking at screening for pulmonary disease. So usually the way we do these lectures, at the end of every system, we'll now stop, we'll take, because in the book that I told you, this information was picked. I'm going to share the book. It might not be the current version, but the one that I have, it's the book, but it's not the current version. I will share it. You'll see in the book, at the end of every chapter, you will see case studies. They will talk to you about the history of the patient, how it's been treated, and then they will now ask a question. What are the red flags and the yellow flags in this case? Or they will say, is this case supposed to be referred or not, and why? So usually what I do, I will read, or I will ask someone to read the case, then I will ask the question. Then everyone will participate in answering, and then we'll now scroll up to show the answer so that people can see whether they answered correctly or not. But usually if we do that, we end up having only 1 or 2 systems for the whole day because there are many case studies. And that is why we introduced the Wednesday class. So now what I'm going to do is just to go through the theory in the slides. After every system we'll discuss, we'll move. But on Wednesday, the only thing we'll do is just to discuss the case studies. And I also want you to come up with your own case studies. From now until Wednesday, if you see a patient, try to take at least one system and ask the patient questions about the red flags and the yellow flags, document it, and then present it to us on Wednesday. At least those 4 people that I said you should leave your contacts, I want to plead with you to please help us look at patient and present, because anything I'm going to present to you from those case studies in the book, they are things that happened in the USA and other Western world. And I would like us to have something that is much more peculiar to our own environment. So I will just use that as a guide, but then I would love to see, and it's not just the 4 or 5 of you, I will plead with all others also to do it and share with Dr. Samani, so that we'll put them in one file with your name somewhere, so that when we open it, we'll ask you to present and let us know what happened to the patient. So we can take as many as we can. If we have many from you, we'll even leave the one from the books. Just take 1 or 2 as example. We'll take more of the ones that are more culturally distant. So, but please, let's try to do that. And that's the best way we can learn clinically. Because just listening to this, believe me, you'll go to the hospital, you have the patient, and you'll get lost. But if you try it on a patient, you have the confidence to continue to try it on other patients. And that is what will bring about non-analytical cognitive process that we've been talking about. So thank you. Let's quickly look at screening for pulmonary disease. Just let me know when you want us to take a break. If it is now, we'll go and come back by 2. Or if it is by 1:30, then we'll continue and come back by 2:30. Please just let me know what are your preferences. Do we take a break now, or do we continue for another 30 minutes? Yes, ma'am.
I think we should continue for the next
30 minutes. Yeah.
30 minutes,
Because
okay.
yeah, I think we're still assimilating now. Once we go for a
Okay.
break and come back, yeah.
Okay. Okay, that's fine. Ma, I've seen your hand up. Please, you can unmute and speak.
Thank you, Prof. Good afternoon, sir. Good afternoon, colleagues. Thank you very much. Sorry, I missed out on some of the things you say we should do. My network, was fluctuating, so I couldn't quite get the things we said that we should do. I'm sorry. I don't know if you
No
could
problem
just
at all.
recap.
I think it's good to continue to emphasize because it's an important exercise. I said between now and Wednesday that we are going to have another class in the evening. I think 8 to 11. We are going to have a class, but on practical screening for diseases. So what I want people to do is to, as they see patients, let them add these issues of red flags and yellow flags. Ask them. You can pick one of the systems, maybe neurological system, pulmonary, cardiovascular, as the case might be. Ask them, do you have a headache? Do you have vomiting? Have you vomited? Do you feel nausea? Check for their pulse rate, check for their heart rate, and put down the information. Then look at the interpretations that we have. See if you can deduce anything that shows that the patient has any organic pathology. Then report it. So you can now put the case. This is a case of a 40-year-old so. From our assessment, we saw that this patient has this and this and this and this and this, and therefore I feel that this patient has an organic pathology in the area of this, and therefore I'm going to refer this patient. So a case study, a very short one, not more than half a page, for everyone that is able to see a patient, do these assessments on screening for the systems. So you don't have to do all the systems. You can just pick either the pulmonary system, the neurological system, or the cardiovascular system that we'll look at before the end of today and report. Thank you. I hope that's clearer now.
Yes, thank you very much, sir. I got it.
Yes. So thank you. Okay, so most people say we add 30 minutes. So we are going to check the pulmonary disease at this point. So screening for pulmonary disease, similar in principle to what we did earlier. Number one, we have red flags and yellow flags. Number two, it is about risk factors, symptoms, and signs of diseases. We need to know them. We need to know how to assess them before we now understand how to do the interpretation. So whatever we have on these slides are the interpretations, but what is important is for us to be able to know how to assess each of these individual information on the patient. So basis for referral to a physician, family or personal history of pulmonary disease. So you want to suspect organic pathology in a pulmonary system. Can you see risk factor in this? So when you are now taking your family social history, remember in the APTA template, there was a place on family history, and they said hypertension, heart disease, diabetes, and a number of other ones. People will fill it in, and then you are going to have an open-ended question about any other condition. We need the materials will be sent to you. I assure you of that. So if the patient has a family history of pulmonary disease, and can you see it is not specific on what condition? So if there is family history of a pulmonary disease, or there is a personal history of a pulmonary disease, the patient has had a pulmonary disease in the past. Then there are pulmonary symptoms of systemic nature. So maybe the patient cough and it's productive, especially if the color is green or yellow. So this shows a pulmonary symptom that is systemic in nature. When there are absence of findings indicating neuromusculoskeletal lesion. So for example, someone might fall and hit their, and have the ribs or the muscles around the chest injured. So, or possibly there is shoulder pain. And that shoulder pain, the palpation does not increase the pain. Movement does not increase the pain. So if there are absence of findings indicating neuromusculoskeletal lesion, there is family or personal history of pulmonary disease, and there are symptoms that show systemic nature like coughing, and that is productive. This is a red flag. Quickly refer the patient. When there is sudden onset of dyspnea, so the patient has difficulty in breathing and it just comes suddenly. He has been doing his activities, no difficulty in breathing. And all of a sudden, just the breathing becomes difficult. And the difficulty in breathing is accompanied by weak or rapid pulse. So you take the pulse and you realize it's weak or it's rapid. And there is decrease in blood pressure. Can you see why these signs are vital? Because they are the ones that will help you to be able to know if there is need for referral. When we are talking of medical legal things, your record in the file of the patient shows that you did not check the blood pressure. Just because you think you're a physiotherapist, just go into exercise. You did not check the pulse. You didn't check the breathing of the patient. Or maybe you reported the breathing, but there is no blood pressure or pulse. If the patient falls and dies, or anything happened to the patient, the moment they come, the first thing that they will look at in your file, when they later realize that it was because the patient had a condition, that these are signs of red flags that determine referral, and you have not referred, especially if the patient came to you first contact. Because if the patient comes to you from another professional, possibly, even though you will still be responsible, but you may share the responsibility. But if the patient comes to you first contact, and you did not record blood pressure, you did not record pulse rate, you may have recorded dyspnea because you see the patient having difficulty in breathing, and that is obvious. So if anything happens to the patient, you did not refer the patient immediately when the patient has a red flag, because you didn't even measure to know if the red flag is there, then you'll be in trouble. So dyspnea, decrease in blood pressure, weak or rapid pulse. This put together, there is suspicion of pneumothorax, especially after chest injury. So in your history, the patient may have reported chest injury. The fact that they have reported chest injury, you have taken their blood pressure, their pulse, check with dyspnea, especially if it is sudden onset, refer the patient quickly. Symptoms of inadequate ventilation or CO2 retention, respiratory acidosis. So please, Dr. Samani, take note of this. We are going to have, because you don't need to be a cardiopulmonary specialist to be able to know this. It doesn't matter what specialty you work. Screening for referral is for everyone. This is a general knowledge and skill. Everyone must do it, because you are not going to say, if this patient comes, let me send him to the cardiopulmonary physiotherapist to do this screening for pulmonary disease. And then when he finishes, you now send him to the cardiovascular team to now look at, then you send them to the neurological team. No, it's you that's going to do systems review for all the systems, because it's general knowledge. It is not a specialized area. That is why systems review is part of DPT. As undergraduate, that students are expected to do all these things. These are all undergraduate things. They are not postgraduate issues. And I've told all those that are running, because unfortunately, the DPT curriculum in CCMAS, the new minimum benchmark that NUC did, unfortunately, it does not have this course. And I know some universities that have started running it with their 30% included without systems review. And I've told them, whoever does that degree and completes it, those that are with us will do transitional DPT. Some are even doing it now. If you know in your curriculum there is no systems review, talk to your institution. Let them know they should add it. The issue of radiological interpretations and investigations is also another course. You can have DPT and you'll have doctor on your license, even though I'm not speaking as a registrar now, but I'm still, this stops me from being a registrar, so let me let you know. If it comes to the board, you have certificate that says DPT will not recognize you until you do those courses. Because as we are discussing now, you can see what we are saying. First contact, you have to know this. You don't know this, you can't do first contact. And therefore, we can't screen you and clear you and say that you can go and do first contact when you don't know this. And what we are doing now is not enough to cover what is in the curriculum. And therefore, when you come, you say, I've taken these courses with Ray, 2 or 3 certificates. You say, no, you must go through 12 weeks of lectures and hands-on, so that at the end of the day, we'll now look at it, examine you, and then we'll now give you the recognition. But if your university covers all the courses, then it makes life easier for you to get that recognition and move forward. Sorry for the digression, but I thought it's important to emphasize that. So please, we are going to look at issues of assessing respiratory acidosis, inadequate ventilation, or CO2 retention. How do we know it's there? Because it's one thing to say that if it is there, refer. But how do I know it's there? So we are going to look at this. Then red flag signs/symptoms and previous history of cancer, especially that of the lungs. Whenever there's history of cancer, red flag signs/symptoms. So these are signs and symptoms. So just like the ones that we are looking at here, but I have a feeling that I should have meant yellow flag signs and symptoms, I think, because if you have a red flag signs and symptoms, it's just a referral. So why add previous history of cancer? So this, I think, should be yellow flag signs and symptoms. So if you have yellow flag signs and symptoms, any of the yellow flags will see ahead, and the patient has had previous history of cancer, especially cancer of the lungs, then it is a red flag. Quickly refer. Shoulder pain aggravated by respiratory movements, very important. Whenever the patient says, I have shoulder pain, ask them, when you take a deep breath, what happens to your pain in the shoulder? I have shoulder pain. Shoulder pain is very closely related to the breathing, the respiratory system. And maybe at this point, let me explain 3 different mechanisms for referral from an organ to the musculoskeletal system. Number 1, embryology. At the embryological stage, there are some tissues that are at the same level. But by the time it grows and it becomes into a child, one would have shifted off, one down, or one remains where it is. Those tissues that are at the same level, even if they move away from each other, if one has a problem, it refers pain to the other. That's number 1. Number 2, shared pathway. So you have at the roots of the cervical, the spine, at every root, you have nerves that move to supply musculoskeletal system. And you have nerves that move to supply the viscera. In as much as those nerves leave the same level, the nerve that supplies the viscera, if the viscera has a problem, it will refer pain to the structure being supplied by that nerve that leaves the same level and goes to that structure. That's the second thing. Then the third thing is pressure from an organ. The kidney is very close to the diaphragm. Now, the diaphragm and the shoulder, they share the same common pattern. And therefore, if there is a pathology in the diaphragm, it is always going to affect the shoulder. But now the diaphragm is okay, it's normal. But the kidney is inflamed. And because it's inflamed, it becomes expanded and it touches or compresses the diaphragm. Now the diaphragm is going to refer pain to the shoulder. So you'll be thinking of referral from the pulmonary system, but you ask all questions about the pulmonary system and nothing. Then you now begin to ask questions about the kidney. And at the end of the day, you'll see signs there's a kidney problem, it's inflamed. That's when you will now interpret that it is the kidney that compresses the diaphragm, and the diaphragm now refers pain to the shoulder. So very important to take note of those things. We are going to see pictures of how viscera refer pain to musculoskeletal areas so that we can be able to know whenever a patient presents with those musculoskeletal pains or problems, we always ask questions about the viscera that is always related to them. So shoulder pain aggravated by respiratory movements. Then you ask the patient, hold the breath. So whenever I take a deep breath, the pain in my shoulder increases. Then ask the patient, hold the breath for some seconds. Then assess the pain in the shoulder. Does it remain constant? The patient says yes. Then you know this problem is coming from the respiratory system. Reassess symptoms. When they take a breath again, they say the pain increases. Oh, it is the pulmonary system. So breathing. Decrease or elimination of symptoms suggests pulmonary or cardiac source, because the pulmonary system and the heart, they all refer pain to the shoulder. So shoulder or chest pain that decreases with lying on the painful side. This is called autosplint. So your shoulder pains you. But when you lie on the side of that shoulder, the pain decreases. Why? Because if there is irritation of the pleura, when you lie down, it compresses, and therefore it will not expand on that side. It will expand on the other side, and therefore the pain will not be there. And that shows it is because there's a problem on that side that when you breathe, it refers pain to the shoulder. So musculoskeletal colleagues, whenever you have pain in the shoulder, you keep giving shortwave diatemy and exercises, it's not getting better, begin to think of the pulmonary system or the cardiac system. In fact, the shoulder is the part of the body that gets referral of pain from many of the viscera. Biliary system, hepatic system, even the GIT. You all refer pain to the shoulder, but we'll see all those patterns as we look at the other systems of the body. Shoulder pain that increases with supine positioning. So when you lie down supine, the pain increases. But when you sit or you lean forward, that is why sometimes you see patients, they sit down and they do this because the pain decreases. Or they sit down, pain decreases. But the moment they lie down, so some patients will say, I could not lie down. I was sitting, I couldn't sleep. They thought it's just they couldn't sleep. No, it's just because lying down brings pain. So they will have to sit, or they will have to put their hand, lean forward on the table, or just lean forward without putting their hands on anything. That relieves the pain. That shows it's pleuritic. The pain is pleuritic in origin. So ask all these questions. Your pain, does it change with breathing? Your pain, does it change when lying on the affected side? The pain in my shoulder pain, right shoulder pain. I lie on my right side. Does it change? Then when you lie down, compared to when you are sitting or leaning forward, what happens to you? Pain in your shoulder. Now we are not even talking of the pain in the chest. We are talking of shoulder pain. So all this shows that there is an organic pathology in the pulmonary system, and therefore you refer the patient. When you have weak, so I think all this that I've talked about, they are normal things. I don't think they will require any hands-on, but we can add them just so that, especially if you can be able to get patients that have that problem of shoulder pain changing with positionings. That can be a practical case, but apart from that, I'll see all these as straightforward things that only require us to assess, to ask the patients to go further and establish more. Weak and rapid pulse and decrease in BP. This shows pneumothorax, possibility of pneumothorax. When the patient coughs, has difficulty breathing, and there are constitutional symptoms. So fever, check the temperature, sweats, you can see that. Ask the patient, do you have nausea? Whenever you suspect, they say either systemic conditions or constitutional symptoms. Whenever you have one or two, ask about the other. The patient has fever. Do they sweat? Do they have nausea? That's a constitutional problem. And the patient has difficulty breathing and they cough. These things put together, the interpretation, there's organic pathology. Refer the patient. Muscle weakness. So this is a musculoskeletal case coming to me. I assess the muscle power is low. I do the muscle gut reduced. The patient has headache, localized or radicular back pain. Think of lung cancer. So initially when I saw this, I said, why should I even think of lung cancer with only this? And it is a red flag. But then that's what the evidence has shown. When patients have muscle weakness, muscle atrophy, they have headache, localized or radicular back pain. So that's my worry, that there's nothing in the chest that indicates that I should suspect a lung cancer. So I'm still going to do a little bit more research on this, because I still, unless if anyone has any reason to believe we should just straight away refer to a pulmonologist, I think I still need to search why. Because muscle weakness, muscle atrophy, headache, localized or radicular back pain, and I suspect a red flag for pulmonary disease. At the end, if anyone has any comment, help us. If not, I will do more research. By the next class, I will report back. Hemoptysis.
Yeah.
You cough
Okay.
and you have blood in the sputum, or dyspnea, so difficulty in breathing, on exertion or at rest. So whether on exertion or at rest, you see hemoptysis, blood in the when you spit, or you have difficulty breathing, and these are not proportional to the patient's situation. So if, for example, the person had a chest injury and maybe something pierces the chest, and the patient has been seen by a doctor and they have been given drugs, and he coughs and there is blood, then that's fine. That's not a red flag, because they are already on medication. A doctor has already seen them. They have diagnosed. They have given them medication. There is no need to refer. But there is no accident. There is no reason why blood should come out of the chest. But the patient has blood, and there is difficulty breathing. So not proportional to the patient's situation. This is a red flag. Refer. When there are intercostal tears, patient comes to you, open their chest, and the intercostal area there are tears. That's a straightforward case. Because organic pathology, we said either there is breakage, discontinuity of soft tissues, all this straight away is a red flag. Refer. So what are the yellow flags? Now, can you see what I was talking about? Usually yellow flags, you have the risk factors. And if you look at all this, they are only risk factors, no symptoms, no signs. In number one, less than 40 years. So this pulmonary disease, less than 40 years is a risk factor for pulmonary disease. History of smoking, many years, and not just one stick per day, at least 5 sticks per day or more. Then you have past medical history. So the patient has had breast cancer. Or if it's a male, he has had prostate cancer, kidney cancer, pancreas cancer, colon or uterine cancer. Any of these past medical histories, and history of smoking, and the patient is less than 40 years, this is a yellow flag. This is a yellow flag. Continue to monitor. Red flags for lung cancer, hemoptysis, persistent chest pain, and unexplained weight loss. Yes. Yes, that's also is a red flag. Thank you. Recent history of upper respiratory infection. Anyone that has had recent history of infection in the upper respiratory tract, monitor them to see if you are going to have other symptoms or risk factors that together they form a red flag. When you have musculoskeletal pain that increases with respiratory movements, so it is only pain increasing with respiratory movement. If we go back, you'll see that the other one that we had more information than just this. And that is why this is just a yellow flag. Because the musculoskeletal pain increasing with respiratory movement, depending on where it is, depending on where it is, we'll need to find out, is it really the respiratory movement that leads into increase in the pain? Isn't there any other thing? Decreased respiratory movements on one side. So when you inspire, on one side, the movement is more than the other side. This is also a yellow flag, because there could be a number of reasons that is not organic pathology in nature. That also applies to this one. There could be a reason that you have that apart from an organic pathology, and we need to know what that is before we refer. Unexplained weight loss. So you just begin to lose weight. But that is coupled with the fact that the patient is having difficulty breathing. So we need to relate the two. Is it as a result of the difficulty breathing that we have the unexplained weight loss, or are they things that are separate? The patient, for some reason, just has difficulty breathing. It's not organic pathology. But another condition is making them to have weight loss. So those separate things may not really lead to a referral. Pain does not change with motion or change in position. It doesn't change with motion. It does not change with position. Pain not relieved with trigger point therapy. So if you have a musculoskeletal pain, it should be relieved with trigger point therapy. If it's not, or when you palpate, it should increase. So those things could mean that there is referral, but really there is nothing that links it directly with the pulmonary system for you to begin to say it is the pulmonary system that refers. You need more information to link the two before you make a referral. Pain not increased by palpation, I've mentioned this one. If I have pain in my shoulder, when I palpate, it should increase if it is musculoskeletal in nature. But if it is not musculoskeletal in nature, then it's a referred pain. Then I need to begin to think of the chest. So what do I do to make it a red flag? I begin to ask questions. How is your breathing? Say, oh, I have difficulty breathing. Do you cough? Yes, I cough. When you cough, is there sputum? Yes, there's sputum. Then this put together with the fact that pain does not increase with palpation, then we'll say this is a red flag. But just the fact that you palpate and pain does not increase, you can't implicate the chest and begin to refer. Substernal or chest region, anterior, posterior to the side. So you have pain in the chest when you have pulmonary problems. So this is showing where you can have pain when you have a pulmonary problem. But still, none of them will say it's a red flag that you quickly refer. You have to link it to the pulmonary system. The pain that is of pulmonary in nature radiate to the neck. I'm going to show you pictures. It goes to the trapezius, to the costal margins, to the thoracic back, scapula, the shoulder, and the medial aspect of the arm, which is medial here. So the patient can feel pain in the medial aspect of the arm, and it could come from the chest. It increases with inspiratory movements. So when you breathe in, pain increases. It decreases by lying on affected side. We have mentioned this. Shoulder pain increases with lying supine. I think we have already mentioned this. So possibly we'll have the pictures now. Yes, we have the pictures. So can you see the trapezius that we talked about? Can you see in front the substernal, in the chest, and then thoracic back? These are some of the places mentioned earlier in the slide before this. So whenever your patient has pain in the shoulder, in the trapezius, in the neck, in the middle of the chest, the thoracic back, always ask questions about the pulmonary system, the breathing, the coughing, the sputum, and a number of other things that have to do with symptoms of pulmonary disease. So these are other areas. See the trapezius, see the shoulder. Remember, it said the medial side of the arm. And down to the fingers, the little and this finger. So this is the presentation. You have the costal. You have here, sometimes you even have around the abdomen. This is the back. So pulmonary system can refer pain to all these areas. So if a patient comes to you presenting with what seems to be musculoskeletal, then you need to go back to your red flags and see if there is any link with the risk factors, symptoms, and signs that put together, you may need to refer the patient for pulmonary medical diagnosis in the pulmonary system. So this is the pulmonary system. I don't know if there are any comments or questions. I had someone trying to speak earlier. If there are any comments, let's take them, and then we'll take a break. When we come back, we'll continue from cardiovascular system. Yes, Hadiza Abdullahi.
Hello, good afternoon, sir.
Afternoon.
My patient is like, when a patient is being referred with already established medical diagnosis, and you, as a physiotherapist, you do all this screening and rule out the red flags and yellow flags, and at a point you are good to go with the intervention. So during the intervention, like when you are giving the patient exercise and the patient starts having the symptoms of the dyspnea, all those red flags that you mentioned, what is one supposed to do at that point? Thank you.
Thank you very much. I think the very good question. These issues of red flag and yellow flag and referral, I think I mentioned something like that earlier. It's not just at the level of assessment that you see those and you refer. Even at the point of treatment, you may have seen something that looks like a yellow flag. So you see the risk factors. This patient is over 40. The patient has had past history of cancer. The family, the father or mother has had a pulmonary problem. And you said, this is a yellow flag. But by the time you come into the treatment, you begin to give the patient their exercises. Then the patient said, shoulder in my pain. I said, when? He said, it has been there for long. Why didn't you tell me? I'm treating your knee. That's why I didn't ask you for, see, that's a mistake. You said you didn't ask because you didn't review the systems. You didn't do systems review. And the patient now reports shoulder pain. I say, shoulder pain, since when? Sometimes back. When does it increase or decrease? Yes. What increases it? Whenever I take a deep breath. You now begin to say that, okay, I had in my assessment risk factors because this patient is less than 40. I didn't do any interpretation because I didn't even think of cardiopulmonary system. I'm only thinking of the knee. Can you see why I was telling you APTA will not ask chief complaint until they do what is evaluation of the risk factors, biodata, past medical history, family social history, drug history. They will ask about 23 questions because there are 23 to 24 items before they now begin to ask about the chief complaint. They will have evaluated. They will say, okay, let me sit back. From all these things, what system do I suspect as yellow flag? So this patient is under 40. This patient is a smoker. This patient has parents that have had pulmonary disease. This put together, there are yellow flags for. Then when you now get into your history, because you already have yellow flag during your earlier evaluation, you will not leave the chest alone. That is when you now do your systems review. And you say, okay, do you have any difficulty breathing? Do you have? So, but if you didn't do all that, because you went with the Nigerian system, BPT system of patient coming, sitting now, what's your name? What brought you to the hospital? What is your chief complaint? That's okay. That's fine. But you are treating the patient. The patient now wins his, after breathing, he wins and touches his shoulder. What's happening? Shoulder pain. You took a deep breath. And I saw that. What's happening? What's the link? Yes, whenever I have the, then put together, I say, okay, Tashi, get up. Let's go. This is a red flag. Go. They'll go, get the diagnosis. That does not mean that when you refer, you don't keep the patient. No. I'm treating your knee. I've confirmed there is a physical diagnosis. You are my patient. But because of what I've just seen, it's a red flag, it's an emergency. I want you to quickly go and see the physician. And the moment you finish with him, I want you to come back. So you'll go see the physician, come back. That day or another session, you'll now continue to treat the knee. You don't have to treat the shoulder because the shoulder is not a musculoskeletal problem. It is a referred pain. The moment the treatment for the pulmonary disease is over, that one will also go. But you keep. So that is why the decisions you can take might be 4. You keep the patient because there is no suspicion of organic pathology. There is only physical diagnosis. You refer the patient because there is no physical diagnosis. There is only suspicion of medical diagnosis or organic pathology. You keep and refer. There is a physical diagnosis, but there is a suspicion of an organic pathology. Or you consult. There is something that you are not even sure of. You now want to sit with another professional to have a discussion so that you clear the air and know which way it goes, either medical diagnosis or physical diagnosis. You consult. These are at least 4. There could be more. These are the 4 decisions that you can take at the end of your clerk. Thank you. Yes, Mr. Anozie.
Yeah, thank you very much, Prof. Just like a rider to the question you were just answering regarding if the patient is already during the process of, let's say, the patient is having this treatment and the red flag pops up, and from my experience, there are sometimes you meet a patient. For instance, let me give an example. I had a patient who had taken his vitals, who was supposed to participate in an group exercise class. So the vital signs, the heart rate, the blood pressure, before the exercise was just within the acceptable range limits and everything. And the patient, we did the warm up and we started the exercise. But during the patient was just doing the cycling, I just noticed that the patient was just leaning forward and just stopped. And, and was just complaining of chest pain and all that. So immediately I rushed immediately to him and I found out he said, he was just talking. I also noticed that he was having the sentences were, broken, showing that he was dyspneic and he was interrupted. So there was shortness of breath. There was chest pain. He was touching his chest, saying he was having chest pain and everything, So at that point, I already knew that, so there is a problem. Likely there could be an angina pectoris or something, And at the point there, I needed to really, really, help the patient immediately because he was short of breath. I checked the SpO2 was already dropping to, it was like at 91% at that point. And I was like, oh, what can I do immediately? So I called for help. We removed him from the bicycle and sat him on the wheelchair, and eventually was wheeled to the emergency because the patient was really breathless. And even the forward-leaning positions for the patient to be able to breathe properly and try to control your breathing exercises before we get there could not even restore the SpO2 to the normal range limit. So eventually we went there and they did a quick scan and everything, and they eventually found out that this patient was having an angina. So I think the doctor eventually used I saw it on your slide, nitroglycerin, had to just slip it under the patient's tongue, under the patient's tongue. And within just a couple of minutes, the patient, the situation was relieved and all that. So had it been I didn't act that fast and everything, it would have turned into something else at that point. So I'm thinking in physiotherapy clinics, especially where we're having our exercises, can we have things that are going to be compliant with emergency preparedness, like to act? Because obviously, as a physiotherapist, I had already seen that this patient, there was no signs that this patient would have this problem. And there was no previous history of any cardiac problems prior to that time. The patient was just coming to, to do fitness training. I want to improve my exercise tolerance. That was his goal. And that we're working towards that. He said he wants to improve exercise tolerance. But that happened during that period. So I'm thinking, with the knowledge of what we are seeing now, that once we see a red flag, we must escalate and refer to the appropriate medical professional to manage the patient. So, but what in the interim, especially something that requires a timely intervention, what can we do as physiotherapists? Are there protocols that we can put in place in different places? Like someone has mentioned about oxygen therapy before, and things like that. Apart from the CPR basic training that most of us have about resuscitating, but that's if the patient goes into cardiac arrest. What of other conditions like this that happened? I remember also when I was doing my internship, the patient went into hypoglycemia after just performing a mat exercise, and I was really scared about everything. It was my supervisor that I identified it, and they were able to just give the patient Coke at that point, and the patient was able to come back. Okay. So I'm just talking. Yeah. A lot of things.
Let me just ask you this question. Now, when you were assessing that patient before the point that you planned the treatment and you took the patient to treat using the treadmill or whatever it is that you use, did you screen for the pulmonary and the cardiovascular system, a proper system review? Did you do that?
No, what I just did was basically about the basic heart rate, the blood pressure for the patient. Then I asked the patient to, instructing them on, if you feel dizzy while exercising, you need to stop. If you feel sharp pain in the headache and everything. But the patient didn't even complain. He was already leaning forward because of the breathlessness. Then I noticed there was a problem.
When you're assessing patients, they may not report those problems. But your systems review is what is going to now identify those things. Remember, I told you, the patient thinks as a physiotherapist, you just give exercise, and that's what you do. And therefore, if the patient has pain during urination, do you think the patient will come and tell you? They will not tell you, unless if the patient does not know that you are a physiotherapist. Maybe if they come from the village, they just think every person they see in the hospital is a doctor. And therefore, they will begin to tell you everything that's bothering them. But believe me, if it is an educated person that knows the difference between physiotherapy and medicine, they will not be telling you. If you even begin to ask them, what's happening to urination? If someone is not a patient person and they are very direct and straightforward, they will tell you, what has that got to do with your profession? Because I've had someone, in 2013, I was invited, I just returned from my PhD. I came back home and they invited me to speak. When I spoke, the person at that time was a special advisor to the governor of the state. And he's a medical doctor, I think with a master's or a PhD at that time. But what I presented on was the issue of clinical practice guideline. And I talked about things that he never thought were physiotherapy. When I finished, he stood up and ignorantly said that what I'm expecting from this young man is that he's going to talk about this. And he was bending his hand up and down like that. I said, that's ignorance. The guy does not even know what physiotherapists do. And therefore, you'll have someone come and you ask him about his urination, and he's going to get angry. And he will tell you, why are you asking me about my urination? So what I'm saying is that there are things patients will not tell you. You need to prompt them because you know how important those things are. And those things are there, you will not know about them because they are not obvious. If you see someone sweating, you will know. If you see someone breathing with difficulty, you will know. But if someone has pain when urination, you will not know. When someone has change in frequency of urination, you will not know. If someone has pain in their shoulder when they lie down on that side or something, you will not know because they are not lying down at the time that you are seeing them. So these are things that you need to prompt. And if you prompt those things, you will get the information, you will now interpret, evaluate, and then you will say there is a risk of having this, even before you get to the point that treatment will trigger something. That's number one. Number two, before you give patients exercise, especially the kind of exercise that's aerobic, you need to test for their exercise tolerance. After looking at yellow flags and red flags, you might have even missed them. Because when we say doctors misdiagnose, do you think we are better than them? They will do assessment, we must get something if it is there. Sometimes we ourselves will miss it. So if you miss it, you do your exercise tolerance, it might tell you something. This patient, this scores that I've gotten is not really matching the situation of the patient. Now let me go back and do more assessment to see if I will fish out something that I did not fish out during the assessment or the examination. And this is something that I believe, Dr. Jubil Samani, are you here? I think last year we did something like this, maybe Dr. Badaru. I remember people praising him for presenting something very well. And I think this year is also in the schedule. Dr. Jubil Samani, am I right?
Yeah. Yes, sir.
Okay, wonderful. So I think these are things that we need to know. Number one, do your proper screening. Then number two, before giving exercises, do your assessment of the exercise tolerance of the patient and their capacity to be able to take the exercise that you want to give them. Because the exercise you give them will depend on that tolerance and capacity that they have. You will now match it. And I think we are going to look at all these things as time goes on. Thank you so much. I saw Dr. Ajiboye's hand up, but now it's down. Ma, are you still there? Do you still want to speak? Yes, please, ma.
Yes, good afternoon once again.
Good afternoon.
And I want to appreciate Prof for the exposition he's giving us right from the beginning. You are a gift to physiotherapy profession. There is no doubt about it. And my prayer to God is that God Almighty will preserve your life, prolong your life,
Amen.
to be able
Amen.
to have more impact even in this generation. I've been listening to the presentation and I quite appreciate the way you are dishing the thing out. I had a comment before and I have to lower down my hand because the area I wanted to talk about, you mentioned it in response to the last question. And I feel repeating what you have said may not be necessary. But apart from that, sir, I want us, I'm talking to every participant, including myself. Even during examination, we should not just limit ourselves also to just asking the patient, do you have this, do you have that? I think carrying out those exercise protocol or those movements will reveal more to us when we are doing our screening, more than, because some patients may not have that knowledge of knowing whether when they breathe, they see this. But if you instruct your patients to breathe in and breathe out, and you palpate the shoulder as you are doing your screening, it will reveal even what the patient cannot verbally tell you that this is what is wrong with me nowadays. So when we are doing this screening for either the red flags and the yellow flags, we should lay our hands on this patient to be able to confirm, even if they tell us that yes, they are having it or they are not having it, we should confirm it before we can just write it down that okay, this is red flag and this is yellow flag. And apart from that, I want to say something also about our documentation. We should have it at the back of our mind because we are not the only one that will manage that patient. We should have it at the back of our mind also that when we are asking the question, we are not just swallowing all the information to ourselves. We should document it that in case you are not in the clinic tomorrow and another person want to follow up on that patient, it should have sufficient information on the paper or on the system, depending whether you are using paperless documentation or you are documenting it in the paper. Prof made allusion to one of the red flags that that other time that you are saying that you are still going to research on it. I think that bullet point is not standing in isolation. I think it is connected to other things that have been raised before then. So if you are now having additional point like that bullet point, one is assessing a patient, the knowledge of clinical reasoning and clinical decision making should make us to connect one aspect with the other to be able to reach to the conclusion of saying that no, I'm not touching this patient, I'm referring this patient for further investigation or for further management. Those are the areas I wanted to touch. Thank you.
Okay. Thank you so much, Matt. Thank you very much. You are one of those that we are going to invite when we come to do those practicals on these assessments, especially the part of cardiopulmonary. Thank you so much, Ma. I always wanted when people that have that experience come up and talk to us. As I've said myself, I see myself as participant sometimes. I learn from all that you say, all of you. Thank you so much. May God bless you all. So I think we are going to take a break. And now that we have extended it on to 1:52, what time do you want us to come back? Should we come back by 2:30, 2:45, or by 3? What time do we prefer to come back?
I think 45 minutes break will be ideal.
Okay. Yeah. I think 3 p.m. is okay.
Okay. So 3 p.m., is that a consensus? Do we all agree with 3 p.m.? 3, okay. So I can see another person saying 3. Okay, that's all right. So we'll go on break. I will come back by 3 p.m. But it's going to be 3 p.m. for 3 p.m. So now the moment it's 3 p.m., I will start whatever the number that we have on the platform. Thank you so much, everyone.
Thank you, Prof.
Thank you, Prof.
Thank you so much, Prof. Yeah.
Thank you, Prof.
Thank you. Dr. Ajiboye, Ekushel.
Yeah, Emma.
Thank you, Prof.
Thank you very much, sir.
Yes, sir.
I go screenshot the correct page.
Okay, you are all welcome back. So I'm going to share the slides so that we can continue. Okay, sorry, little technical issues. So red flags, as I've said, the only difference is what constitutes red flag for cardiovascular disease. So we have symptoms of TIA, history of disease, heart disease. So when from the past medical history, and that's why it's important sometimes to list those that are commonly, when you have history of them, they constitute, together with some symptoms, they constitute red flags. So you ask the patients directly whether they have heart disease, whether they have had heart disease, diabetes, hypertension, and a few other common ones. And then you leave an open-ended question. Is there any other disease or injury that you have had in the past? And also, have you had any surgery? So usually the patient may not be able to tell you they have had a particular disease or injury, but the fact that they have had surgery and you get the history of the surgery, you'll be able to know if the surgery was about a particular disease, and that is going to give an indication that that disease was there. So symptoms of TIA. So we know the symptoms of TIA. Then someone has that, but they also have history of heart disease, hypertension, and they also use tobacco. And remember, I said use of a tobacco is not just 1 stick per day or 20 sticks per day, but once in a week or once in a month. We are talking of something that is 5 and above and consistently been taken. So when you see that, it's a red flag. So always ask about the past medical history, heart disease, hypertension here. And then under social history, asking about tobacco use is important. And then in your assessment, you see symptoms of TIA. So sudden onset of focal neurological symptoms. Then changes in pattern of angina. So it increases, the intensity increases. What this means is that when you have the pain, it's mild pain, but now it's moderate or severe in intensity. So the intensity of the pain has increased. So the patient knows they have angina, but the pain intensity is at the same level. But now the pain intensity is increasing, or the threshold of the stimulus decreases. In the past, when you walk 3 kilometers, the pain does not change, or it doesn't come. But now, when you walk half a kilometer, you begin to feel the pain. Or if you do exercise on treadmill, the pain now comes earlier than it used to, or the speed of the movement. In the past, you can move fast, it doesn't come, but now even moving slowly will bring it up. So it's about the threshold. The threshold decrease. So it doesn't have to be a long distance before you begin to feel it. Even a small distance now can bring it up. Then increase in pain duration. So in the past, when the pain comes, it doesn't last long, especially with medication or with rest. But now it stays longer than it used to. So all these changes in the pattern of that pain, either the intensity, the threshold, or the duration of the pain, is a red flag. Then myocardial infarction pain. So this is not reduced by rest, change in position, or nitroglycerin. I think Minister Anzonzia earlier mentioned the issue of giving a patient nitroglycerin. We were on this page when he was making the comments and he saw this and mentioned it. So when myocardial infarction pain, usually it will be reduced when the patient rests, when the patient changes position, or when the patient takes nitroglycerin. So, but if that patient pain comes, and now, even when the patient is resting, the pain does not go down, the patient changes into a particular position that in the past will help reduce the pain, but now the pain is still there. Or when they take nitroglycerin, it goes down, but now it's still the same way. This is a red flag. This requires immediate referral. Then sudden increase in intermittent claudication. So this shows thromboembolism. So usually activity and rest will change the pain that you feel across the limb, but now those changes, you don't see them. That shows possibly there may be thromboembolism and there's need for referral. Chest or breast pain in women. So this is in women. And that is why, remember earlier we talked about the past medical and family social history for women and men. For women, we talked about breast cancer. For men, we looked at prostate. So if it's a woman and there's a family history, either the mother or grandmother has had breast cancer or heart disease, and the woman has chest or breast pain. So these are symptoms. So the patient has chest or breast pain. And in the family history, you had already recorded family history of breast cancer or family history of heart disease. So in that case, it's a red flag. You quickly refer. When there is palpitation. So palpitation is a symptom. So the heart rate increases, and there is family history of unexplained sudden death. So that is why sometimes patients may not report that any of the family member had a heart disease. And so the question usually asked is whether there was an unexplained sudden death in a family member. So you have family history. So under family history, either you report family history of heart disease or unexplained sudden death. And also more than 6 palpitations per minute. So the palpitation that we are talking about, at what point do we say this is a problem that, combined with family history of unexplained sudden death, is a red flag? When there are more than 6 palpitations per minute, lasting for hours. So it continues, 6 per minute, and it continues for hours. You have pain, shortness of breath, so difficulty breathing, fainting, the patient might even faint, or there is lightheadedness. This put together is a red flag. Feeling moderately or severely winded, climbing a single flight of stairs. So normally you climb a single flight of stairs, but now the patient will feel moderately or severely winded. So they like getting fatigued, having difficulty breathing as they get towards the end of the flight, the stairs. That also is a red flag. I would have thought this would be a yellow flag, but it's coming under red flag because, I mean, even if you have walked long distance or you have done lots of activities, you should be able to climb 1 flight of stairs, not 6 levels that you walk. A normal person will still feel winded. But this is just 1 flight of stairs. No matter how the activities are, if you begin to climb and you are okay with your breath, then you should be able to get to the end without feeling winded. So, but this is someone that has not even done any activities and they just climb and they feel winded before they get to the end. Refer them. Fainting without lightheadedness. So the patient, so this is sudden. So if there is lightheadedness, dizziness, or nausea, then we might think of something else, not the cardiovascular system. So when someone has not eaten, or when someone has another system of the body causing dizziness or nausea, like the GIT, or any, well, that's either eating or any other problem of the GIT, you will begin to have those symptoms of dizziness or nausea before someone faints. But this is just sudden. There were no signs that the patient would faint, and the patient just faints. So this shows that maybe heart valve or arrhythmia. So this is a red flag and needs referral. Do you mean no audio all this time? Wow, I've been speaking for like how long?
There is audio. We have been hearing
We've been hearing you very loud and clear.
Dr. Fine, please check your network. Because he scared me. He just said no audio.
We've been hearing you since.
Okay, wonderful. Thank you. Yes, so known CVD, cardiovascular disease. So in a known CVD, keep checking the message. Okay, just keep checking so that I'll just get the feedback as I move. Okay, so in a patient that known CVD case, so the patient is on medication. Patient is on medication. So no, that's not a red flag, not a referral case. So it's non-CVD. But in that patient that is known to have CVD, they now have cool or sweaty upper back. So can you see sometimes how will patient tell you that their upper back is cool or sweaty? So by knowing that the patient has CVD, sometimes these checks will be important. Cool/sweaty upper back. And then remember, we talked about pulse pressure earlier. I think it was under neurological system that we talked about pulse pressure. So in this situation, you have a difference between the diastolic and the systolic, and a difference that is greater than 40 millimeter mercury. So that is why it's very, very important, not just taking the blood pressure, but looking at the difference between the systolic and the diastolic. If the difference is greater than 40 millimeter mercury, and the patient is a known CVD case with cool and sweaty upper back, this indicates a red flag. Refer the patient. Intermittent claudication, nocturnal aching of foot. In the night, the foot is painful. Ischemic rest pain. When you are resting, there shouldn't be pain. You walk, you feel pain. When you sit down to rest, the pain should go down. So you have it in the night. When you walk, if there's pain, you sit down, resting, there is still pain. And there are skin changes. You begin to see bruises in the skin. And the patient reports not falling or scratching anything against the skin, but still there are bruises. So this might indicate vascular occlusive disease. Is a case of emergency, is a red flag, refer. So always ask about pain in the lower limbs, in the leg. How does it change when you rest? When do you have it? Is it during the day or during the night? So these are questions that help with the interpretation. Nocturnal aching of pain, you will know at what time, either during the day or night, that they have the pain. You also know whether it's during activities they have the pain or when they are resting that they have the pain. Skin changes are obvious. You will either see them or the patient will report having bruises or skin changes, and all this put together indicates possibility of having vascular occlusive disease, case of referral. So these are yellow flags for cardiovascular disease. I remember I said mostly yellow flags, you either see risk factors alone, or you see a symptom, but that may not be directly related with the cause that might be attributed to organic pathology. So you have a cause that might be something different, and that is why you need to follow up. And also when you see risk factors, it doesn't mean the disease is there. The risk factors are just saying this patient may be at risk of having this. So if they are modifiable, you try to modify them. For example, if it is someone is a smoker, you try to advise them to stop or reduce the number that they smoke. If it's a drinker, if it's a lipid profile, there are things you do to reduce the lipid profile, either medication or exercises. If the person is has sedentary lifestyle, you try also to advise them and guide them to start physical activities. So these are things that are very important to now prevent the disease from coming. So that is why it's not a case of referral, it's a case of follow-up to see that apart from the risk factors, is there any sign or symptom that will be noticed that will now indicate a red flag and then a case for referral? So when you see all these risk factors, if they are within the scope of your practice, we might not say you don't refer. So let me say that you don't refer to that cardiovascular specialist. So it might be a referral to a nutritionist. It might be a referral. So if it is about sedentary lifestyle, it's within your domain. Therefore, you are keeping it. If it is someone that is smoking and drinking and they have that addiction, they cannot stop, then maybe the social worker, whoever it is, that can be able to handle that can be referred to. But when we say it's a yellow flag, don't refer, even though there are risk factors that need to be modified or adjusted, or someone addresses them, you are referring, but not to the cardiovascular or pulmonologist or the cardiologist. So intercostal muscle or periosteal trauma. So someone has an accident, and the accident affects the area of the chest, intercostal muscles or periosteal trauma, and the patient has chest pain with vigorous coughing. So when they cough vigorously, there is pain in the chest, and they have given a history of trauma that affected the intercostal muscles or periosteal trauma. So this put together the history and the symptoms, red flag. Recent history of pericarditis. So can you see our past medical history should be broad? Should be broad. But it all depends on the patient, their level of knowledge, the fact that they will be able to know what diagnosis they have had or not. Sometimes it is the drugs that the patients took. I'm happy sometimes you go to see a patient and the first thing they will do is to pack all the drugs and drop them. The ones that they are taking now, the ones they took 6 months ago, the ones they took 3 years ago, they will pack everything and drop it. So if you have knowledge of drugs, you'll be able to say that, oh, was this through prescription by your doctor? He said yes. And you see that it's a drug for a particular condition, you can deduce that there was a history of that condition. So when there is recent history of pericarditis, and the patient has chest, neck, left shoulder pain. So they have pain in their either chest, their neck, or their left shoulder. So when it comes to the heart, remember, mostly it is the left shoulder. So the same side of where the heart is located. And the patient also has difficulty breathing, dyspnea. The pulse rate is high, it has increased. The blood pressure has increased. So can you see a mix of past medical history and symptoms? So these are symptoms, but you have a past medical history. Put together, it gives you, oh, it's supposed to be a red, that's what I thought, to be a red flag, but it's under yellow flag. So let's see. So you have recent history of pericarditis. The patient has recent history of pericarditis. Now, chest, neck, left shoulder pain, dyspnea, increase in pulse rate, increase in BP. I would have thought this would be a red flag. But then, since there was a history of pericarditis and it's recent, the patient may have these symptoms as an extension of what was being treated in the recent history of this. And therefore, there is need to investigate further. Have these symptoms been there from the time that the patient had the pericarditis until now? Or is this something that was treated and then recently these symptoms now began to come back? So that's very important to check so that if things are cleared, then it could be that there will be need for another referral to see if it is the same condition or it is another condition because it's still looking like an organic pathology. Sudden onset of pain with activity, shoulder and neck pain might indicate thoracic outlet syndrome. So sudden onset of pain with activity, shoulder/neck pain. Now this could be, because if you remember what we did under pulmonary system or pulmonary disease, there's something similar. So that is why I said sometimes when it says yellow flag, it doesn't mean it's not a red flag, but it only means that it might not be a red flag for this particular system, and therefore you need to find out. And possibly it might not even be a red flag for referral for organic pathology. It might be a red flag, but it's still within the scope of your practice, and therefore it's not a referral case. It's something that you consider. And there's nothing like a red flag for something that I consider, because definitely I'm going to assess it and treat anyway. So it's a red flag when you are going to refer because it's an emergency. Someone needs to pay attention to it. So history of CAD or MI, but apart from the history, the patient has symptoms also: chest, shoulder, neck, or temporomandibular joint pain. So naturally, this could have looked like a red flag also, but need to confirm, where is the chest pain coming from? What's the possible source? The shoulder pain, is there any reason for there to be a shoulder pain? Is it musculoskeletal? Did the patient have an accident? So that is what it means to further check, so that it can be truly attributed to the cardiovascular disease. So what even think twice and further check is because of the fact that these symptoms come together with a past history of heart problems. So if not, we would have thought it's musculoskeletal. But since it's a past history, it's possible it has been sorted, it's not there, or it's under medication. We need to now check, palpate the shoulder, palpate the TMJ, do your tests, make sure that they are not responding, and therefore meaning it's not a musculoskeletal problem. Then you can now link it to the past history and begin to think of referring the patient. Pain in upper part of the body after activity involving lower part of the body. So biking, stair climbing. So when you have pain in the upper part of the body, which is the lower part of the body that did the work. So you did biking for a long period. What you are expecting is to have pain in the lower limbs. If you do boxing, you are expecting to have pain in the upper limbs. Someone will hit you in the trunk, you are going to have pain in the trunk. So whatever it is that you do, you are expecting that part should be the one to have pain. When you do biking, you do stair climbing, you sit down and you have pain in your upper part of the body, this is a yellow flag. Because the heart is up there. When there is pain up there, even though the activity was done by the lower part of the body, we should be conscious of that, do further investigations. Risk factors of CHD or treatment of angina. So these are risk factors. So we'll look for risk factors of CHD or history of angina. Now it's there from the risk factors from the first part of our family social history, family history or social history. Then we have shortness of breath while walking with arms extended. So what you do is to pick objects from a height. And when you are trying to put them up, it takes time before you remove your hand. So you have shortness of breath, which you are walking with your arms extended over the head. So you are reaching to pick something from up, or you are reaching to drop something on top of something, stay for a while, you now begin to have shortness of breath. And this is in a patient that has some risk factors of CHD, or they have past history of angina. So you can see also history with shortness of breath. But because of the fact that this is an activity that we'll need to find out, if someone has some problems musculoskeletal in the upper limbs, the exertion of trying to reach out will make them to feel difficult in breathing possibly. So all this is saying is that check for other things and rule out the link of whatever symptom you have with the heart problems or cardiovascular system. Also have arrhythmias in spinal cord injured, cardiovascular accident, traumatic brain injuries, so the SCI, CVA, TBI. So you have arrhythmias in these patients, and the patient has dizziness and increased pulse. So you can have things like this in neurological conditions. Have dizziness, you can have increased pulse. So when you have arrhythmias, so that is why it's not a direct case. Therefore, you need to check to confirm that it is cardiovascular in nature, not just some of the symptoms that come with a neurological disease. You have throbbing pain at base of the neck. So at the base of the neck or the back or interscapular areas. And that pain, when there is exertion, it increases. It's a yellow flag. So that is why it's important to understand the different types of pain. I think in the DPT that we did, there was a course on pain, the different types of pain and the interpretation of having those pains with linking them with different conditions and different system problems. So if the pain is throbbing, it's at the base of the neck, at the back, or in between the scapula, the scapulars. And this pain, when there is exertion, you do a walk and you get tired, you are exerted, that throbbing pain in those locations increase, is also a yellow flag. Now let's look at the pain where it's referred to musculoskeletal system. Remember, I told you the shoulder is a very common place where viscera refer pain to. Remember also in the pulmonary system, we saw pain around the medial part of the hand. But in that one, it could be on the left or on the right. But in this, that affects the heart, is going to be on the left side. So it's going to be on the left side. The shoulder will be affected. The trapezius will be affected. The neck will be affected, and the temporomandibular joint will be affected. Then part of the chest. From the back, you will see the neck. You see in between the scapula, but especially towards the left, you're going to see the shoulder, trapezius, neck, and then around the scapular region. So this is it, left shoulder and arm, ulnar nerve distribution. So remember, ulnar nerve distribution, the little finger and the ring finger. And from the back, have the left scapula. The shoulder, of course, can be seen and other points there. So this is, every patient may have different presentations. Patients may have different presentations. For this patient, you can see it's just around the chest. We don't have the neck, the temporomandibular joint, the shoulder or the trapezius. So this is localized in the chest. In this patient, there is no pain referred to the medial side of the hand. There is no pain in the shoulder, no pain in the trapezius muscle. We only have the temporomandibular, the neck, and the middle of the chest. It's also a common combination. So patients can present like this, but it's still the cardiovascular system, the heart especially, that is referring the pain. Then in another presentation, you'll have the chest, neck not affected, temporomandibular not affected, but the trapezius, shoulder, right medial aspect or the ulnar distribution, middle of the heart. But in this case, apart from the left side, you also have a referred pain in the right side, but only in the medial side of the arm and the forearm. In this patient, you have just below the, what do you call this, end of that bone that is in the middle of the chest. Just above the breast, in the middle of the chest, and just around the side of the mouth. So these are all possible distributions that you can have with cardiovascular, and all this could mimic musculoskeletal pain. Many of our patients will come and they will present with pain in these locations, and we'll begin to give them massage with neurogesic and what have you. Pain is not going to be relieved because the source of the pain is not there. Nothing will change. Do all that you would. If you don't refer the patient to a cardiovascular specialist, the patient is not going to get better. And how do you know that there is need for referral? We now go back to the red flags and yellow flags that we have looked at earlier. This is another distribution. So the heart has different distributions. This is another one from the temporomandibular joint, the neck, and then in the middle of the chest. Another patient can have only the temporomandibular and the neck. Another patient is only the shoulder and the medial side of the arm and forearm on both sides. You can have only in the mid-back, mimicking, I think, one of the pulmonary system that we saw earlier. And this also is there in the middle of the back, so between the shoulder blades. So that's it for cardiovascular disease. I will go straight into gastrointestinal diseases because of time. So I will do the two and then we'll have discussions, because I think on the flyer it's 4. So that even if we go beyond 4, it's not going to be too long after 4. Gastrointestinal disease, I think, is a system that we hardly deal with as physiotherapists. But it also has organic pathologies, either that will be underlying diseases that need to be treated early, or that they refer pain to some musculoskeletal areas that we treat as physiotherapists. And therefore, it's very important for us to screen the gastrointestinal system. So what are the red flags? Sudden changes in bowel habits. So the way you purge, it changes. Either you purge more than normal, or it becomes watery, or at least it changes its shape and the way, things like that. So that it's sudden. It has not been given signs over sometimes. It's just sudden. It just becomes like that. Because usually, possibly as we age, or when someone is, the changes, has change in environment, or changes the type of food they eat, all those can give you signs that something will change, the bowel habits will change. But you have not changed all those things, and suddenly the bowel habits just change. Or when you see blood in your stool, whenever you see a patient reports blood in stool, and sometimes, as I've said earlier, patients will not report. You need to ask them. If you have a reason to believe that there is a gastrointestinal disease, but believe me, sometimes even if you don't have any reason, asking these questions, I know someone will ask me a question, how within the period that I have, I will do all these things? My hospital, we are only 3, there are 100 patients. I keep answering that question. Tell your management, if you want to do something reasonable, you can't be seeing 60 patients when you are only 3. Each person sees 20. Nothing is going to change in the services you provide. Patients will not get better. First sign, pain in shoulder. So vomiting blood. So whenever you vomit and that's a red flag. Bowel habits change. You see blood in stool or vomiting. So blood in stool with the changing in bowel habits, vomiting red blood, changes in bowel habits, each of this combination is a red flag. Refer the patient. There is an gastrointestinal disease and it's organic in nature. It's an organic pathology in nature. When you have pain in shoulder while lying down and legs elevated, so the patient is lying down, elevate the legs, and you have pain in shoulder, so there is no pain in the shoulder. But the moment the patient lies down and elevates the leg, pain comes in the shoulder. This is a red flag. Trauma or ruptured spleen. So when there is rupture in the spleen, when you lie down, raise the legs, there will be pain in the shoulder. When there is epigastric pain radiating to upper back. So when you have epigastric pain and you feel pain in the back, usually when you have peptic ulcer, pancreatitis, or pancreatic carcinoma, you'll have epigastric pain, and this radiates to the upper back. When you have abscess of the iliopsoas muscle, now, we are going to have a workshop. Dr. Jibril, please take note of this. I forgot to really ask for us to include it as part of the series that we are going to have. And this is one of the most important things after our workshop on human movement system. I'm going to show you the importance of having a workshop. I can't remember the name I given to it. There was a name. In fact, we wanted to do a workshop some years back, around 2015. We wanted to do a workshop in collaboration with a college in Poland. But our Nigerian colleagues were not happy. They said, what can help people from Poland show to us that they will come and collaborate with us to do workshops? People did not sign up. We didn't do it. It was someone that had that expertise in locating muscles and being able to know what activities those muscles do, and their combination of muscles that give particular activities or tasks that the body do. So if you want to touch your head, which muscles are activated and they do the activity? If you want to pick your cup, reach out and pick your cup. And how do you know if a muscle is contracting? What muscle is it that is contracting? How do you locate them? So those things are very important because we are movement specialists. What we do is to treat human movement system disorder. So there is no way we can do that if you don't know the function of muscles. This goes beyond origin and insertion and action. It goes beyond that. I think I once mentioned here, I was treating a patient, and the patient, from the accident that the patient had, they have weakness in their adductors. But the way I was strengthening the adductors, I later realized when the patient comes to do activities of daily living, it is not just pure adduction that the patient needs. So if you want to kick a ball, you don't kick the ball from one leg towards the other leg. You need the adductors, but you also need other muscles, like the rotators, say external rotators, and then other. So how do they combine to perform a particular task? It's important for us to know that. So how do we locate the iliopsoas muscle? Because right now I give you a patient, I say, assess this patient. Do they have abscess in the iliopsoas muscle? This might be challenging to some people that have forgotten their anatomy. So please, we are going to look at muscles, their locations, their contractions, and how they come together to perform activities of daily living. Then hip, thigh, groin pain. So the patient has pain at the hip, and their thigh, and in the groin. And the iliopsoas muscle has abscess. This may indicate that there is appendicitis. So what the patient is going to report to you is that they have pain in their hip, and that's it. They might not even show pain or indicate pain in the groin or in the thigh, or at least in the groin. They will say hip and thigh, and you'll start thinking that it is a low back pain or it is sacroiliac joint dysfunction, and you keep assessing. It's even possible when you palpate, you might feel the pain, because when there is abscess, you might still feel pain. Or because of the way the posture of the patient is, to avoid the pain in that region, they might put the muscles in a state that there's going to be spasm. And all that could lead into pain while you palpate, and you'll assume it's a musculoskeletal pain, but it might not be a musculoskeletal pain. It is when you look at this as an indication of appendicitis, especially with the abscess in the iliopsoas muscle when assessed, that you will now begin to see it as a red flag. And this is a gastrointestinal problem and is also an organic pathology. Refer the patient. The moment they treat the appendicitis, the hip, thigh, and groin pain will go, because all your short-wave diatemy is not going to treat that. Arthritis and migratory arthralgias. Today you have pain in your knee, tomorrow it has jumped to your hip, next tomorrow it has jumped to another place. So you want to treat it with short diatemy, the knee today, and then tomorrow you move it to the hip. This is more or less a sign that there is Crohn's disease. It's an organic pathology. Refer the patient. Yellow flags.
last distribution.
Dr. Jibril, I don't think you know you are unmuted. Nausea. Sorry, Dr. Jibril, were you referring to me?
No, sir, sorry, I was talking to Abby.
Okay. I was wondering, yes, okay. So nausea, so just because someone has nausea, it might be from a food that they ate, they're not used to, and they feel that they are going to, so it might not be an organic pathology. That's what I'm trying to say. Maybe the moment they vomit that food, they don't need any treatment. They just rest and drink water and they continue with their activities. When there's dysphagia, when there is anorexia, early satiety. So all these yellow flags you need to continue, because just because you get satisfied, immediately you begin to eat. There could be some reasons. Some people just get angry, they start to eat, just feel they want to eat. So that does not mean that there is an organic pathology, and therefore continue to follow them up until it build a case for a red flag. Alternating back and abdominal pain. You have back pain, it stops, it goes back to the abdomen, and then the other way around. So that also is a yellow flag. Shoulder pain increases by belching or antacids. The pain is there, but the moment you belch, you know, when you eat, you belch. So when the pain is there, you belch and the pain goes down. The pain is there, you take antacids and the pain goes down. There is likelihood that there is a gastrointestinal problem. Shoulder pain decreases within 30 minutes of eating. The pain is there, you eat within 30 minutes, no pain, or it goes down. And it now increases 1 to 3 hours after you have eaten. So before you eat, there is pain. You eat, the pain goes down. 1 hour after you have eaten, the pain comes back. Oh, there is an indication that this pain may have been referred from the GIT. Then appendicitis or iliopsoas or obturator abscess. I've put in a video from YouTube. That's what is called the McBurney's test, positive iliopsoas or obturator test, positive test for rebound tenderness. So all these are about appendicitis or iliopsoas abscess or obturator abscess. When you watch the video, you're going to see how the tests are carried out so that you can do them to rule out possibility of having an organic pathology as opposed to a musculoskeletal problem that will be around the groin or hip or the thigh. So these are the areas where the GIT can refer pain to. So you can see the numbers. So you have all these are part of the GIT, isn't it? Stomach, duodenum, liver, gallbladder, bile duct, small intestine, appendix. That's why in those yellow flags, we looked a lot about appendicitis and other things, esophagus, pancreas, large intestine, and colon. So you have the stomach sending pain and duodenum sending pain to this side, just around the chest. You have the liver, gallbladder, bile duct, the same pain below the breast on the right side. So on the right side, the liver, the gallbladder, the bile duct. Then you have the small intestine, navel, in the middle. You have appendix. Of course, we know appendix is on the right. Just down below the stomach, close to the groin. And then we have the pancreas, more towards the left, but close to the area where you have the stomach or the duodenum. And then you have the large intestine at the lower part of the stomach, just close to the groin. So these are the areas that pain will be referred to from the GIT. You can agree with me that if not because someone knows that GIT can refer pain to these areas, if patient reports pain to those areas, in heart or lungs, when you see distributions around here, or you might think it's a musculoskeletal problem. Say, did you have an accident? Did you hit your chest somewhere? Did you do this? Did you do that? And you feel pain around here, you'll say, oh, this is, if from the back, aha. So for example, this one, that's the one that will even think more that it is our case. The small intestine, see the shoulder. Can you remember the shoulder? Right from the pulmonary, we got to the cardiovascular, we got to, so now we're gastrointestinal. I think which one is it that we looked at after? Okay, cardio, okay, this is the third one. So can you see all of them? All of them send pain to the shoulder. And I believe as we go forward, you'll see many others sending pain to the shoulder. Low back. So you have low back pain. Colon can send pain there. See one surprising thing. The esophagus that is up there is now sending pain around the coccyx, sacral coccyx. Down there, the esophagus. So you have all sorts of distributions that all may look like musculoskeletal, but it is coming from the GIT. So I think because of time, and it's even possible that hepatic and biliary are part of what we are going to take next Saturday, then I think I'm going to stop here. As I've said, in the evening of Wednesday, maybe I will use 1 hour out of the 3 hours to present on the case studies that are here, that I picked up from that book. I will share the book so that you can be able to study it before we come. And what I'm going to do is to present the case, then I will ask the questions. And then all of us will discuss, will say what we think it is, what are the red flags there, is it even a red flag or is it a yellow flag? Why do you think so? Therefore, going back to study what we have done now will be key, because that is what will determine our answers to the questions I will raise in the case studies. We'll do that for 1 hour, and then after the remaining 2 hours, we'll now take case studies from participants. So give us what you have done on your patients based on Yes, I think I lost the network, but I'm back now. Yes, I'm back. Sorry, I think it was the network. I'm back. Yes, so I think the ones that remain, I think we stopped at the hepatic and biliary. So hepatic and biliary, we'll be looking at those symptoms and signs and risk factors that make red flags and yellow flags. Then we'll now take the urogenital disease or system. And after the urogenital system, we'll look at the endocrine disease. Remember, I told you when we were discussing the human movement system, I said the musculoskeletal is the effector, neurological is the regulator. I said pulmonary, cardiovascular, and endocrine are the supporters. And then the integumentary surrounds all of them. So we'll also take the endocrine because problem there could affect movement. So we are interested in it, but at the same time, there could be an organic pathology that will require referral. And then after that, we'll take hematological. So how do we know that there is a hematological problem? Oh. Okay, sorry, are we back? Or have you been hearing me? I thought I'd lost the network.
Yes.
Okay, I think, okay, I'm back, sorry. Okay, so hematological diseases and then integumentary. Then finally, okay, so how do you know there are red flags for referral for oncology and then pediatrics? Now, I know the number of systems are more than just the 3 that we have taken. But why it's not going to take us a very long time to cover them is because today we took a long time with the background and introductory aspects, understanding the concept of the systems review itself. And therefore, next time, if we take 30 minutes for each of them, we'll be able to cover all this remaining about 6 that we have not touched. So then on Wednesday, after that, next Saturday, we'll then have the evening session that is going to be only for the case studies. I will also use 1 hour to present the case studies across board, maybe 1 case study or 2 case studies for each. And then after the 1 hour, we'll also take case reports or case studies from the participants. And that way, we will close with the series for screening for systems review. So I have an important announcement or discussion that I want to have with you on way forward, but let me open the floor for discussions, and then we'll discuss that, and then we'll close. So thank you so much, everyone. May God bless you all. So any questions or comments are welcome. Okay, I can see a hand up. Mr. Anozie, please go ahead.
Thank you very much, Prof. I really learned a lot from your presentation, and it's also stimulating for me, in this area of systemic evaluations, reviews, and being able to rule out red flags and yellow flags, and the way it's going to help us to be able to first contact practitioners and also being able to make appropriate referral and escalate conditions and help the patient. So eventually, it's making us a better practitioners. So my suggestion is, it's like, I believe these are the things we're supposed to be covered in details in the DPT program, I suppose.
Yes.
Yeah, so I just want to encourage each and every one of us now, if this is one stimulant for me to really want to register for the DPT, because I was just like been wondering like DPT stuff, and I believe some people have been skeptical about it, even though, but now I can see that, oh, there is really much to gain. And if we really are open to, improving our practice, and getting more skills and more professionalism, it makes more sense to me and all that. It's not because I was really worried about is it just going to be having the title of the doctor and not really having more knowledge and more skills and everything. So, but now I can see really that by the time someone has a very good grasp of all this system review and other skills that will be acquired, definitely, it's not just going to be ordinary. So I would encourage every one of us here, if you have not registered for the DPT program, try as much as possible to register or make a plan for that so that all of us will get at the same pace and we all stay in our platform. I can imagine myself who have passion for the respiratory. And if I am very, very vast in identifying red flags and yellow flags, you definitely a patient comes and you are doing what you are doing, you're able to have a very good rapport with the MDT, and you're also going to give your own expertise in your own field. It makes a lot of sense. So thank you very much, sir, for this training. I'm really, really, I think it's really, really worth it. Thank you, sir.
Thank you. Thank you very much. Let me say that from what you have said, yes, this is, in fact, I picked all this from the DPT curriculum of Michigan Flint University, from what they gave us. So all these are part of the DPT. The only thing is that in the DPT, it's going to be a semester, whole semester thing. So 12 weeks of lectures, reading, assignments, discussions, group discussions. It's a lot. And we felt we couldn't even cover more than half of what we wanted really to cover in the whole 12 weeks. So what we have here is just synopsis, trying to just touch things. So it's something that requires much, much more than that. And I want to give us a good news. I was in the NUC 2 weeks ago. I met with the director, academic planning, and I complained to him that, look, in the curriculum, you said universities will have to wait until they get to 500 level before transitional can join them. That's number one. Number two, I said these are professors and directors that are teaching these students, and you want them to come and sit down in the same class with them. So I will teach, and then I will now come down and sit down when another person is coming to teach. It doesn't really, it's not going to work well. These are also people that are working in clinic. As I was speaking, he just stopped and he said, well, you are making a lot of sense. I said, and we are always happy to listen to these realistic things from regulatory bodies. But he said, please just write it down, send it. It's going to come to me anyway. I'm the one that will make recommendation to the executive secretary, but write formally. When they send to me, I'll make that recommendation so that we'll give the chance to universities all to start the transitional DPT instead of waiting until it gets to 500 level. It will take a very long time before people do their transitional DPT. So I'm still going to go back on Monday to follow up and see if the ES has already mentioned to them or whether we have gotten the approval. Then we'll now start to do advocacy for universities to start all at the same time, and also try to make it separate from the entry level, and also try to consider the fact that people are working. It still has to be a physical thing, but consider that people are working and make it flexible for them to be able to achieve what we want to achieve, but at the same time, they're able to do their jobs. So God willing, we are going to get there very soon. And that's one of the things that I wanted to discuss with us. I want us to have a train the trainers for these areas, so that when this thing starts all over the country, it will not just be the people that have done DPT in other countries that will be able to teach. That is one of the reasons possibly why it has not been in the CCMAS, because people have not studied. So why would they know that it should be there, necessarily be there? So I want us to have a situation in which we'll have at least 1 or 2 persons from each state. Then we'll now do train the trainers. Then after that, you'll find out that when it starts all across the country, there are people that are very, very much familiar with it, and they can be able to be the resource persons to teach either in the universities or as individuals doing their trainings to people within their state. So, but we'll discuss that before we finally close so that we can put things in motion. Dr. Jibril Samani can help us anchor the coordination, and then we'll see how we can do the trainers. Thank you. Dr. Ajiboye, please.
Thanks so much for the opportunity to speak again. Actually, my concern is on this transitional DPT program and the DPT program that is to commence nationally. there are issues with the curriculum that came out from the NUC as per this DPT program, and especially the transitional one and the CCMAS. The major courses that differentiate BPT from DPT, they were excluded. When I saw the CCMAS initially, before they now said that, okay, we should look at it program by program and then include, if not because we have started the DPT program at Chrisland, by height will not be opened to all the courses that were supposed even to include that were excluded in CCMAS. And we have to sit down and add what the courses that are supposed to be there that were excluded. This system review was not there. Physical diagnosis was not there. Many, if in fact, evidence base was just there in part. When you read the course content, you know that there is nothing to write home about. So having this in mind, I feel that there is still a lot that MRTB will do. The transitional program that I don't want to mention institution, that we feel that maybe we have started in Nigeria. If you look at the curriculum, which a few days ago, I was able to have access to the one that is being run currently. We cannot say that that is transitional program for DPT, because majority of the courses that were listed there was just in line with Bachelor of Physiotherapy program. The reason why I'm shouting out like this, sir, is it possible for you to, as the MRTB registrar now not on the platform of Ray, to send to all the institutions that the MRTB want to see the content of the program they are running, that they are calling DPT or TDPT program, so that instead of allowing them to graduate their students, before now MRTB is now looking at the content of the training and now say that no, I cannot take this one for transitional program. I think that will go a long way in helping us, and it will go a long way in helping those that have registered and they think that they are doing transitional program, whereas the content of what they are doing is nothing to write home about. So just a prayer from me, sir. Contact all the institutions. Let them submit. Yes, let them submit what the program the curriculum they want to be running or they are running, and evaluate it. If it's not up to the standard, alert them immediately. Because they say when two elephants are fighting, it's grass that will suffer. It's the product of that program that will have issue.
Exactly.
So I'm pleading with you and I'm making my prayer known here. Though I know it's not on MRTB platform, but we are privileged to have you as a facilitator in this program. So that's just my submission. Thank you.
Okay, thank you very much, Ma. I think instead of asking institutions to even send us their curricula, what we'll do is to just take the CCMAS. I will now have a team. God willing, on Monday or Tuesday, we'll constitute a committee with people that have done DPT or those that have know what it should have. And that team will ask them to look at the CCMAS, look at the actual DPT curriculum, and bring out areas that are compulsory. There are areas like the systems review that we are talking about now that are compulsory, and then we will now write to all universities. We'll say we understand that NUC has given you the mandate to come up with the 30%. But we want to let you know from the perspective of the board, any institution that does not cover these other areas in their 30%, then their products will not be licensed immediately. They have to do a makeup for them to be licensed. That will make them to sit up and add it. But because now we are collaborating very strongly with NUC, we'll then write to NUC to say that we understand the concept of having 70% by the NUC and 30% by the institutions. We understand that, we agree with the NUC, but we want to recommend that NUC review the 70% to include these courses that are compulsory and make sure they are there so that there will be no variations across universities. Every university must do that. What is not compulsory is what should be constitute the 30% that institutions should cover. So I assure you, by next week, we are going to do that. I remember last clinical reasoning that we did. Someone raised an issue about the issue of the template. How can we harmonize it? I think there was also another question that I said I was going to constitute a committee to do that. Anything that comes off as a gap from these workshops that we're doing, I assure you we are going to consider them. One good thing that makes me very happy is that there are so many people with capacity and passion and commitment that want to help. So when to set a committee and give a task is not a problem for us here in the board, and therefore I can assure you all these things can be done. So the only thing is that I will ask you to please help. If nothing has happened within a week, help reach out to me, because usually I have a lot that I pick out in workshops and meetings, so that you follow up and make sure that we have constituted the committee and it has started its work. Thank you so much, ma'am.
Thank you so much, sir.
Yes, I can see either Dr. Jibril or Hafiz is raising hand.
Yes, sir.
Do you want?
I
Okay,
think
go ahead.
somebody from YouTube has a question.
Okay.
A participant sent me a question. It's on YouTube that he wants you to please come again on the concept of endocrine system as a supporter, musculoskeletal system as the effector.
Okay. Okay, that's wonderful. Now, if you look at what I said, the neurological system is the one that regulates the movement. So if I want to pick my phone to make a call, it is the brain that decides that I want to do that. So the brain decides there is need to make a phone call. I think about it cognitively, and then I make a decision. Then the brain will send impulses to the muscles of the hand, ask them to contract. It is at that point that they become now effectors. They effect what the brain has planned and is executing. But for the muscles to contract, there is need for oxygen. And therefore, the pulmonary system will take in oxygen. But for the oxygen to go to the muscle or the brain, the cardiovascular system must come into action, sends blood to the lungs, pick the oxygen, and then the oxygen now is transported to the brain and to the muscles and to the bone and everywhere that's needed. But there are chemical reactions. To pick for the oxygen to bind with the hemoglobin and be transported, there are substances that come out through the endocrine system. And if you have the oxygen alone, you have the blood alone, there won't be any chemical reaction, there won't be binding, there won't be transportation. Those chemicals or substances need to come from the endocrine system, and therefore the endocrine system is part of the supporters, the pulmonary system, the cardiovascular system, and the substances required for the reactions that will bring about the action of the pulmonary and the cardiovascular. Endocrine is what determines that, and therefore the three are the supporters. Then the integumentary surround all. So if you have an integumentary problem, blood may ooze out, and then you are going to have a problem with the system, or you might have an infection get into the body and stops all these other systems from functioning. So all these systems are systems individually, but they work together to bring about the human movement system. And that is why it is called system of systems. We are going to deal with this much more when we get to that human movement system workshop that we're going to have. Thank you. I think we have Mr. Ifeanyi. Yes, honesty.
Yeah, thank you, Prof. Thank you so much, sir. I want to appreciate you again, sir, for having taken us this learn. It's really wonderful. I mean, we have learned a lot. I myself, and I must thank you especially. What I want to also contribute on the issue of DPT, I think our madam have said it, Dr. Ajiboye, if I'm right. Yeah, she has actually outlined or mentioned some of the issues, that need to be looked into. And I believe that you're going to look into it critically. I once was opportune to see the curriculum, and it was not really, I mean, there's nothing much there, like when you compare it with the BSc or the BPT or BMR, you'll find that I expected more, more of clinical, courses, clinically oriented courses, just like we are having now, system review and all that, even the pharmacological aspect also. There's something needing need to be changed so that, you know, when we're talking about DPT, it should be DPT, it should be able to compete with the world, you know. So that is what I'm advocating, that you please kindly use the office to look into it so that once we kick off, it will really worth it. Once again, thank you so much, sir. Thank you, Prof.
Thank you. Thank you very much. I assure you we'll do that. The institution that everyone keeps referring to, I've been there 3 times in the last quarter of last year, 3 or 4 times. I was there. I met with both the management, the faculty, the department, and we have an understanding and an agreement. In fact, I've received the curriculum, I've looked at it, I've advised them, and I'm going to write back soon to say that these are the areas that should be added, let them be added. In fact, I may also go back again to discuss and make sure that whatever it is that we need to do to have them coming out with all that it takes to be DPT and first contact practitioners, we do. I assure you of that. We'll do that very soon. Yes, Mr. Sunday.
Okay, thank you.
Thank you, Prof. I want to actually, in line with others, to actually appreciate you for this beautiful platform you have created in educating us at various levels. However, I just want to actually speak about this issue of DPT and the transitional program. To me, I believe that there are stakeholders that actually being saddled with the responsibilities of the regulation, of which MRTB and the NUC are actually the major stakeholders that will help us in bringing out the curriculum in such a way that it will have the content from various courses, which will be quite different from the BMR of which somebody has actually mentioned all the time. That the content of this DPT, it should not be something that has to be shallow. The issue of going to universities, those that have actually started, and saying that the institution should give us the content of what they feel. I want to believe that we are the institutions of various angles. They are to align themselves with the regulatory bodies, the MRTB and the NUC. They will not have their curriculum different from what these two regulatory bodies will formulate or probably created for them. And if there's any of such institutions trying to shift their ground and not to incline themselves with what the regulatory bodies is laying down, then it means the approval, I think, it shouldn't have actually scaled through in such a way whereby they will have started. So I want to believe that the MRTB issue, my suggestion, sir, is to collaborate with the NUC and then sit down critically and then analyze the various causes and ensure that it has the content that is expected and meet to the global standard, whereby in the other clients where we have the robust courses with their various content and is equally, so that's the whole two is a regulatory body has to come out with what they believe as regards policies and as regards the content that has to be put on ground and ensure that every institution should go in line with those contents and nothing different than that. Because we cannot be having conflicts of regulations where we have the two bodies that have been shadows with the responsibility and now begin to say we are going to institution. Institution in this case, they are not the one to regulate or to determine which content a particular course for the DBT transition program should have. Rather, it should be the NUC, the MROTB, if I should go by extension, the Ministry of Health, should equally come out with what they know that it should be best of the global best practice for this transition program to run at various institutions. That is my suggestion, sir. Thank you.
Okay. Thank you very much. All these suggestions are noted, and I'm very happy that we are having these discussions, because when there are too many things, you leave out some things. But now that we are saying them, I'm taking note of them. By Monday, I'm going to open up actions on all this and delegate, have people form teams, do things, either developing what should go into it, and then having people follow up in the NUC to make sure that we have that understanding that they also will put it as part of what the 70% should be. And then we'll now come and begin to do advocacy. Let people follow what the minimum standards are for the NUC and the board. So we'll call for a meeting with all HODs, both academic and clinic, that are involved in training. We'll discuss with them, we'll sensitize them, we'll let them know what these areas that we are including, what they mean, why they are important, and what makes the DPT a DPT. And by the time we do all these things, I believe we'll have that sensitization and awareness that we don't really need to have serious activities of enforcement. People will just fall in line and will continue to have the right thing done. So thank you so much to everyone. I think I've exhausted all those that have raised their hands. I think Ma, you raised, I can see your post. I wanted to say that you raised your hand earlier. It's very good that we set out what should be included. Thank you. Okay, so if you have any comment, please, you can unmute and speak, but if that's the only thing you want to say, then that's fine.
Yeah, thank you very much, sir. I just wanted to ask a quick question.
Okay.
I know that it's few persons have done. I know a few persons who have really done the DPT program. And I'm wondering, the schools that have started the DPT program, and do they have enough lecturers per se that would be able to teach those areas that are really DPT specific? I'm not talking about the BPT stuff. Do we have enough to really cover ground, or how do we intend to raise people who will be able to coach stuff? Because if I'm going to join a transitional DPT program and I know that, we have only Dr. Rufai and few other doctors, let's say less than 10 doctors DPT in Nigeria, I'm wondering how is it going to be able to, reach out to the number of physiotherapists there? Or how do we want to really train the lecturers that will teach? I don't understand. That's the only thing that's been going on in my mind. Thank you.
Okay. Well, actually, I was in NUC, and that's the same approach by MRTB. Any institution that wants to upgrade to DPT should have a resource verification. And I know institutions that reached out to NUC and said, we want to switch to DPT because that's the first thing is to get approval of establishing a program in a university. It comes from NUC, but the board now comes in to regulate it. So when they reached out, I know Lagos, University of Lagos, just last week or this week or next week, there will be a team from NUC that will go there. And this is part of the things that they will look at. What do they have on ground to be able to have this? Now, there are times when someone asked, he said, who trained the first PhD? He said, definitely it's not someone that had a PhD. Because if he said a PhD must train a PhD, then there was a time that there was no one. So the same thing will apply to this. I don't want to think that you must have a DPT for you to teach. In as much as the courses are out and this is clearly what should be taught and people are familiar with what they should teach, even if they have not acquired their own, I believe we should be able to start from there. Then at some point, we'll now say that now that we have many people that have done the DPT, it's only someone with a DPT that must teach the DPT. And that is what I was telling you earlier. I foresee that. And I said, let's now have trained the trainers so that even if you don't have the DPT, you have done the trainers, you know what to teach and how to teach it. You can now be able to go in there as a resource person to do that. By the time we begin to produce DPTs, then it's only DPTs that will be teaching that. Yes, so these are some of the things that we are going to do. I can see Dr. Ajiboye's hand again. Ma, you can go ahead.
Thank you so much, sir, for the opportunity to speak again. The last speaker that asked question on that, many people address concern concerning who will teach what and when. And I thank God for the way the the registrar has responded. Even when we started the postgraduate training for physiotherapy postgraduate training, they have to route it through train the trainer or appointments by what? By election. I happen to be one of the first sets that applied, and I am proud even to say that I was one of the 25 people that were selected to be the first fellow of Postgraduate College of Nigeria. We didn't have the exposure before, but they put down some criteria, which if we are able to meet, they set up the trainer program, which is not only physiotherapists that were involved, the orthopedic surgeon, the neurosurgeon, the neurology physician, even including professor of nursing. I could recollect Professor Adejomo. I met her for the first time at the Trainers workshop for National Postgraduate College of Physiotherapy Postgraduate College. And to the glory of God, after going through that trainer, we didn't remain the same again. Even including the professor in the profession of physiotherapy, they were part of that program. And we were inducted and the program started. We may not be where we're supposed to be today, but the thing is changing every day and the thing is getting improved every day. I want to use Chrisland as a template for the program. Chrisland is the first institution to start a DPT program in Nigeria. And I was privileged even to be one of the first people to start even that program. The time the verification was done and we were told even to start, I went to the vice chancellor. I said, if you really want to make this program DPT program, there's a need for us to extend our tentacle beyond Nigeria. And we're able to get resource persons from the US. In fact, we sent our curriculum to the US. Let them evaluate it for us. Let them know where we are. And many courses were added when it was returned to us before we started implementing it. The first year, the second year, our students were doing the normal thing they do at 100 level. They are in a science class. 200 level, they are in basic medical. But before they got to the 300 level, we employ the services of facilitators from the US that was part of this program. And to the glory of God, up to today, the program is not just being run by anybody. My registrar volunteered himself. He's part of our faculty at Chrisland. And he's the one taking even this system review with my students. I told him that I can't be saying much, but if we really want to do the right thing, we know how to go about it to do the right thing. The only thing is that for other institutions that are coming up, I'm proud of Kaduna State University because I know the kind of materials that they have that they are running even the program with. I think about few months ago, I contacted the registrar concerning this transitional program. Presently, the one that is developed for Chrisland has been sent to the US. And they are reviewing our transitional DPT program. And any moment from now, Chrisland will start. If we have the mind of doing the right thing, something good will come out of it. But if we have the ego of, I know it all, I can do it, whether I have the knowledge, I don't have the knowledge. And personally also, Physiopedia is there. There are many of these courses that you can access and go through that you are going to be examined on it before you are certified even to have done it. US also is there. There are courses that you can do to upgrade yourself. But as the matter is today, we need to develop ourselves the more. One challenge that I'm seeing is that some of the people that have gone for DPT, they don't have their masters, they don't have their PhD. And it's a big challenge to us because using them in the university as a resource person, we put some question mark. You have your DPT, but you don't have masters, you don't have PhD. They won't be able to, except they want to give graduate assistance. So, registrars, sir, you have a lot still to do, and I believe you are equal to the task. This thing you have started, continue with it. And if there is opportunity for train the trainer, as let everyone that are faculties in one institution or the other, let them be included, not even a matter of training only one. Let the lecturers that will manage them come for the trainer, so that we will know that at the end of the day, the doctors, they are looking at us. The nurses, they are looking at us. They want to know whether we really have something to show for what you are claiming to have. It's not just getting the title doctor that matters, but having the right things to be able, even to show to the world that we have what it takes. If I graduate my student now and they cannot go to US to practice, they say, okay, their program is deficient. What have I achieved? Am I building them? Am I training them just for Nigeria consumption or for global consumption? So that is my own response to the question you ask. And I believe if all of us are willing to do the right thing will be done in Nigeria. And then we'll be we will place ourselves as the leader of Africa, as by the grace of God we have presently. Thank you.
Okay, thank you so much. Thank you very much, Ma. So I think I'm going to hand over to Dr. Jibril Samani. I know we said we are going to close by 4, but this is a very stimulating discussion, and I appreciate you all for the discussions. If any phrase your hand honesty, I don't know whether it's the old one. If it is another one, please 1 minute so that we can quickly close. Well, I can see, please 1 minute if anyone wants to speak so that people can go and rest. Honesty, please 1 minute. Mr. Anozie, you too 1 minute, please. Go ahead.
Okay, my question is directed to Dr. Ajiboye, because you mentioned something about the master's degree for people who want to start teaching DPT students and they don't have masters and they don't have PhD and all that. I'm from my little understanding, I understood that DPT program is a clinical program, and the PhD and the MSc is actually supposed to be able to help you to work in the academic world and all that. So if DPT is strictly clinical, what's the place? Does having a master's or PhD, does it give any special advantage to teaching students with DPT? I just want to be clarified on that because I don't quite understand the edge a master's degree holder have over someone who has just done DPT and don't have a master's degree. Thank you.
Okay. Am I permitted to respond?
1 minute. Yes, 1 minute, please.
Okay, sir.
1 minute.
Yes, it's not the matter of saying you must have you must have masters of PhD before you teach even the DPT program. As a first degree holder, if you have your DPT and then you are not employable as far as university is concerned, the first degree holder that is employable in university, they are first class students, and they are called what? Graduate assistants. They are not lecturers. So if you have a knowledge and then the environment does not permit you to be able to discharge that knowledge, you have to upgrade yourself and get an institution where the DPT program is housed is university, and not in the College of Postgraduate Physiotherapy College. So that's just the little response. I have other professors around that can speak to it. But to the best of my knowledge, that is what I'm trying to pass across. Thank you.
I think in the academia, DPT is a first degree. And although I understand what you're saying, it's a clinical program, but for university to run the program, it's an academic program. So you have lecturers that will teach and do research. Because what we want is for the students to be able to now understand research so that there will be evidence-based practice, so that they can be able to go out there and invent something and put it through research and make sure that it's something, a product that can be able to be used to help patients. So that is where the academic background comes. Then from the clinical background, that is where you don't need masters or PhD, you need fellowships or become a consultant to now give the skills that are required in the clinic, hands-on, that would be for the patient. You need both. Now, medical doctors made a mistake. They said their fellowship, which is a clinical thing in the hospital, is equivalent to a PhD, and you can become a professor, you can teach in the university without it. Right now, as I speak with you, NUC has said if you don't have a PhD, at some point in time, you can't be a professor. Of course, if you don't have a PhD, you can't become a vice chancellor. And therefore, they are now all running to do their masters and PhD, even though they have the fellowship. Because when you do research, it has to be masters and PhD. That is the academic and research program. Your fellowship is for the clinic. So your DPT is a first degree. If you want to be a researcher and an academician to teach research and theory in the clinic, in the university, you must do a master's and PhD. But if you want to be in the clinic, so that when students cross to the clinic to do their clinical posting, it is not master's or PhD that matters. It is your fellowship or your specialization, clinical specialization, that matters. So both of them are needed depending on where you are. You are in the academia, you must do master's PhD. You are in the clinic, you must do a fellowship or specialization, clinical specialization. So with this, I'm going to close the discussions. I will hand over to Dr. Jibril Samani so that you can close for us. But thank you so much to everyone.
Yes, thank you, sir, for the presentation, and thank everyone for participating. Hoping to see you next Wednesday. Bye-bye, and thank you all.
God bless you, Dr. Samani, for the support.
Thank you, man.
Thank you, Professor. Thank you a lot. I listened to it from beginning to the end. God bless you, sir.
Thank you. Thank you all for this presentation. Prof and Dr. Samani, we appreciate your efforts.
Thank you, Mama. We appreciate you for always being here.
It has a lot. Thank you for your attention.
So let's clear all this. Well, let's switch to now. So that I can leave.